This conference will now be recorded.
Bismillahirrahmanirrahim. Hello, my colleagues, and welcome to our session today about subfertility module. Could you please confirm if my voice is clear?
Yes,
Doctor. Okay. So today we will participate 6 stations related to that module, and we will start first by participating the first scenario, because after this we need to apply general points of history taking to this task. So let's start by the first station. Dr. Aisha Khan.
hello.
Dr.
Yes,
Aisha
yes,
Khan.
yes, Dr. Aisha.
Hello, Dr. Aisha.
Yeah, I'm Asiya.
So this task assesses the following clinical skills: patient safety, communication with patients, information gathering, and applied clinical knowledge. You are an ST5 doctor in an infertility clinic. A couple who were referred to the clinic by their GP have returned for review. She has had oligomenorrhea for the past year. She doesn't report headache, visual disturbance, galactorrhea, or hyperandrogenism. She has been trying to conceive for 2 years. The investigation results showed negative pregnancy, high level of FSH and LH, low estradiol level, normal ultrasound hysterosalpingogram, immune to rubella, and normal semen analysis. Counsel the patient about the results and management options. Now you have 2 minutes.
Okay, Dr. Aisha.
Can you start, Dr. Aisha?
Yeah, hello, I'm Dr. Asiya, one of the doctors in the infertility clinic. May I confirm your name and age, please?
I am Miss Janet John. I'm 28 years.
Sorry, first name?
I am Mrs. Janet Jones. I'm 28 years.
Okay, how shall I address you?
Mrs. Jones is fine.
Ms. John, I understand from your reports that has been given that you are having problem with the periods and you are trying to have a pregnancy. Is that correct?
Yes, right.
And this is your you have came before here and you are here to review your visit. Am I right?
Yes, right.
Do you have any other concern?
Yeah, I wondered what is the cause of my irregular period and why I'm facing difficulty to have a baby.
Okay, I understand your concern, Mr. John. Is it okay that I will ask you a few questions? It will help me to know about you. Then I will discuss with you the reports and I will discuss what is the different options available for you. And how it sounds?
Yes, I'm good.
Okay. So can you tell me about your period?
Yes, my period used to be regular, but over the past year it became irregular, and its length vary between 35 and 60 days. My last period was 50 days ago.
Okay. And did you notice any weight gain in this period? Weight gain?
Yes, I put on some weight, and I wonder if this is the cause of my regular periods.
Okay. And regarding, do you notice hot flashes or night sweats?
Yeah, I noticed that I feel tired rather than irritable, and I feel hot at night.
And is there any problem with the vision or
Sorry?
difficulty in the vision, visual disturbance like?
No?
Okay.
No.
And okay. And have you ever been pregnant before?
No.
And do you have tried something till now? Any treatment taken?
No.
Okay. And regarding your partner, can you tell me some detail about him?
Yeah, it's Peter, and he's fine.
Mhm.
And I think
Okay.
that his semen analysis was normal.
Okay. And may I ask you some question which may be personal about your sexual life? Is it okay?
Yeah, okay.
How you feel towards sex? Your desire is okay or any problem?
Actually, recently I developed some lack of interest in having things, but I'm trying to do because I'm trying to have a baby. But I find that there may be some dryness from that too.
I'm sorry to hear about that. And is there any pain with the sex
No, it's only dryness.
or you feel vaginal dryness?
Yeah,
Okay. And any bleeding after the sex or during sex?
no,
Have you ever had sexually transmitted infections in the past?
no,
Have you ever used contraception before?
no,
And any medical, are you following with your GP for some medical illness like diabetes or a thyroid problem?
no, I'm physically fit and well.
Any surgery in your tummy or below down?
No,
And to whom you are living with?
yeah, with my partner Peter.
And everything is fine at home?
Yeah,
Any medication you are taking on regular basis?
no,
Any allergic to some medicine?
no,
And in your family history, do you have your sibling, like sisters, who have some menstrual problem?
not my sister. My father, her period stopped at the age of 40, and I'm afraid that I will have the same scenario.
Okay. And how is your mother doing now?
Yeah, she's fine.
Okay. And what about your social habits? Do you smoke, drink alcohol, or any recreational
No,
drugs?
no,
Okay. And in your family, like clot formation history or in your personal history?
no,
And how do you feel low depressed for this in this all time period?
no, I'm fine.
Because we have very good counselor. If you need any support, we can refer for support. Thank you for sharing information. Do you want to add anything?
No, thank you.
And do you know about your height and weight ratio?
Um, Actually, I got some weight, but I think my body mass index is about 28.
28, okay, good. And now coming to the concern that this reports, I have confirmed your name and NHS number. These reports belong to you. Someone has talked to you about these reports?
No,
Okay. So first of all, this some tests you have done like X-ray, ultrasound scan, that is good, normal, and also you check that X-ray to check your tube, these are patent, so your tubes are patent, and your one test has done this bug rubella test, it is immune. These are the good, these are the normal tests. And regarding your partner test, we will discuss when, because I can see that you came alone, so we will discuss in the next visit when he will be with you. Is it okay for you?
Okay.
Okay. So now, and also you have done pregnancy test that it is negative. And regarding, there are some you have just tested hormones. Mr. John, that I see that you are alone. Do you want to call someone to be with you?
Why?
Actually, I have some concern about the reports. I am afraid that there are some concern because this report shows that the hormones you have done FSH, LH, these are on the higher side. Let me draw for you, because these are the hormones which are produced by the brain that which stimulate the ovaries to produce the egg. And when ovary is not functioning well, then brain has to work more to stimulate the ovaries. That's why you have high FSH and LH. Am I clear so far?
Yeah, but what does it mean?
Actually, it means that ovary is not working properly. But first, we have to repeat this test again. Have you done this test before in the previous visit?
This is the first time.
Yeah, so that's why we have to do this test after 4 weeks to make it confirm. After that, we can tell that if it's still high, then we can say that from your history and from the test, it is most likely condition that is called premature ovarian insufficiency. Have you heard about it?
You mean like my mother? I will reach the age of menopause early at 28?
Yeah. Yes, I'm sorry to say, because if when the woman have less than 40 years and if the ovary is not working properly, so it is called premature ovarian insufficiency. Let me draw for you that this is the womb and this are tube and ovary, because here the ovary, these are the gonads which release the egg, because egg release and pass through the tube, and sperm will meet in the tube, so pregnancy will occur. So for the pregnancy, it is very important to ovary to release the egg. But here we can see from the report, and if the after the 4 week the result are same, so it means that ovaries are not producing eggs. So that is why that you are having problem not to conceive. Am I clear so far?
Yes, clear. But I'm keen to have a baby. Is that means that I will not be able to have baby in the future? I'm really
I'm
shocked
sorry.
about this result.
I'm sorry that I am giving you this news, but first of all, as I mentioned, that we have to repeat the test, and second, there are many options available. Do you want me to talk about that?
Yes, please.
And because first of all, this in case of premature ovarian insufficiency, what will happen, because ovary is not functioning well, but it has been seen that in 5 to 10 out of the 100 women, they can spontaneously their ovaries start working again, and they can get pregnant in their lifetime. Like natural pregnancy can occur. But unfortunately, we cannot. We cannot predict that which one woman can go for this natural. They can have this pregnancy. Am I clear for so far?
Yeah.
So for this reason, because as you are mainly concerned for the fertility, so we can offer you for the refer to the fertility specialist. They can discuss in more detail. And if you want, there is one option like we can take egg from other women and take sperm from your partner and make a baby and put inside your womb. This is called the egg donation with assisted reproduction. Am I clear so far?
Yes, clear.
Yeah, okay. And any question, if you have any time, please ask me. And and also because as you can see that this if ovary not producing hormones well, so because these hormones are called female hormones, estrogen, progesterone, they are mainly act on the womb. So that's why the changes occur. They have the time finish.
Yes. Okay, Dr. Asia, can you add if you'd like to add any more points?
Yeah, because
Just in
as
points.
okay, so because for as your ovary not producing hormones, so I can refer you for the menopause clinic, because the very important these hormones very important for having effect on your heart and bones. So we can give you the hormones in estrogen, and also to protect your womb, we will give estrogen progesterone like in the
So
form
you
of
will talk about
hormone
the charting.
replacement therapy. Sorry.
You want to talk about HRT?
Yeah, I want to talk about HRT, and because she has concern about fertility, so we cannot offer combined oral contraceptive pills. So we can talk about HRT for her bone and for her heart issue and multidisciplinary team, and for diet, well, diet rich in calcium and exercise and this vitamin D and calcium she can take, and follow up in the menopause clinic. And I will give her appointment for the consultant and refer to the fertility clinic and counselor and sport group. Sorry.
And what if in the next visit she has confirmed the elevated levels of SH and LH? Do you need to add any further tests?
If next visit she has what? Sorry.
High level of FSH, she's confirmed to have premature ovarian insufficiency. Would you like to add or order further tests?
Yeah, because we have to do her blood sugar level, because diabetes can be associated, and thyroid function test, and also genetic. We can do karyotyping by blood test, and also bone density, this DEXA scan.
Yes. Any other thing you'd like to add?
I think enough. This sport group and counselor, and right back to GP.
Okay, thank you, Dr. Aisha. You did it very well. Thank you. So I will start by giving you first the feedback, then we'll discuss about this case. So you did it very well, Dr. Aisha. From the start, you have good opening, and you confirm the aim of your consultation, and you ask about her concern, and you put your agenda, and you start by analysis of the complaint and asking about symptoms of premature ovarian insufficiency. You ask me about hot flushes and night sweat. And when you discuss with me about the results, you're confirming my name and the NHS number, which is part of point of safety. And you start by telling me about the normal results in the investigations. You follow the protocol of breaking bad news. You draw, and also you tell me about my fertility options and do referral for fertility specialists. This is very nice from you to do this during the station. But coming back to the negative point, you know other points of safety and of knowledge, but you don't have time to tell this because you only have 10 minutes and you spend about 5 minutes in history taking. So try to be specific while taking your history and don't repeat questions many times because you asked me about the medication twice. And for every point in the history, only one question. So for the period, tell me more about your period, just only one open question to save time for that. And also, you follow the protocol of breaking bad news, but try to be more empathetic while doing this. And when you tell the patient about the diagnosis of premature ovarian insufficiency, just silence for 10 to 20 seconds to give her time to react. Because you tell me about the diagnosis, you follow the protocol of breaking bad news, but you give me many data and you talk many and don't give me time to react to the diagnosis.
Actually, I do not follow full protocol because as it mentioned that it is only first test was done once only. So that's why I do not follow the full protocol.
Because there will be no station if you don't do the, you need to tell her, as you said, you need to repeat the investigation, but it is likely that she will have premature ovarian insufficiency and go through the approach of this case.
Okay.
But for safety, yeah, you need to mention we need to repeat the investigation, but don't wait until the results will come because usually she will have premature ovarian insufficiency.
Okay.
So follow the protocol, allow her to react, and do not forget that in premature ovarian failure, you need to counsel the patient not only about the fertility option, but about also her general health, because this may carry risk to your heart and to your bone. That's why we need to offer you HRT. You know about HRT, but you speak about this after the 10 minutes have already finished. Also, other option for her fertility is adoption. You said about spontaneous pregnancy and egg donation, but for any infertile couple, talk about the option of adoption. Okay, Dr. Aisha, apart from that, you did it very well. And also, do not forget to offer her patient information leaflets and support group and meeting with a counselor. And as we said before, when you tell the role player about the diagnosis, tell her immediately about the leaflet and support group, because you will not find the time for that at the end of the station, and you will lose its mark.
Okay.
Okay.
Yeah. Okay. Thank you.
Thank you, Dr. Aisha, for sharing.
Thank you.
So I will come back to this patient, but starting first by a general point of history taking. When you are reading the task in the exam, you need to prepare yourself while reading this task and answer the following questions. What is the likely diagnosis of the case? As in this task, the diagnosis is premature ovarian insufficiency. So when I know the diagnosis, I will put in my mind and memorize related points of safety and applied knowledge. So I read the task and I determine its premature ovarian insufficiency. So I will write in my notes that I need to ask about menopausal symptoms. I need to ask about histologies on my suite. I need to see if the investigation has been done twice or I need to repeat it. I need to offer her management option regarding the fertility and about her general health. So once I know the diagnosis, I will memorize this important point of applied knowledge and patient safety. The other question I need to answer is what are the tested domains? If there is information gathering, so I need to go through the history taking, but sometimes there may be no information gathering. So determine what domain will be tested. Other question is how, where, and who am I? Who am I? It's written in the task. I am an ST5 doctor, but don't tell the role player you are ST5. She will not know what is the meaning of ST5. I will introduce myself. I am the registrar. And where am I? I am in the infertility clinic. So I will introduce myself. Hello, my name is Rasha, the registrar in the fertility clinic. May I confirm your name and age, please? And also, it's important while you're reading the task, ask yourself, what is the mode of the role player? If it is a station of breaking bad news, so when I enter the cubicle, I will be neutral on my facial expression, or I need to congratulate the patient for suspicious pregnancy, for example, so I will enter the cubicle with a smiley face. So try to answer this question. What is the mood of the role player? Okay? So in the 2 minutes while preparing, make sure that you answer this question. What is the diagnosis? What's point of safety and knowledge? What domain tested? Who and where am I? And what is the mood of the role player? After that, you will introduce yourself, be confident and clear, and don't speak in hurry, and maintain eye contact with the role player. Don't look to the examiner or to the lay examiner. You only need to communicate with the role player in front of you. After that, when the role player tells you about her name and age, write down her name in your notes, in whatever language you are familiar with, because you will need to repeat her name during the consultation. And be aware that when the patient tells you, for example, my name is Mrs. Sally Jones, avoid the mistake of telling her Mrs. Sally. Mrs. Sally Jones will be Mrs. Jones, because some may do this mistake. Okay? So I will introduce myself in a confident manner. Hello, my name is Rasha, the registrar in the fertility clinic today. May I confirm your name and age, please? Then she will tell me her name. I will write that and tell her, nice to meet you. Then I need to put clearly from the start what is the aim of the consultation. It is written in the task. She has oligomenorrhea. She's trying to have a baby for 2 years. So I will confirm that. I understand that you are here today because you are trying to have a baby and you have problem with your period. Is that right? So I will put my agenda. I need to ask you some questions to know more about you. I need to examine and order some tests. Then I will discuss about your diagnosis and your management options. If that will be okay for you, then you will start the consultation by an open question. Tell me more about your concern. From that concern, you will do analysis of the complaint. So the patient now seeks infertility. So I'd like to analyze the cause of the infertility. I need to ask about if she's ovulating or not, if there is any tubal factor of infertility. I need to ask about her partner. So from the complaint, do analysis of that complaint. Determine the focused history you need to ask about. And you need also to ask questions to rule out differential diagnosis. As in this scenario, she has premature ovarian insufficiency, but I need to rule out that she don't have any visual disturbance, any headache, any milk discharge from the breast. This is to rule out other differential diagnosis of infertility. Then, after doing the analysis of the complaint, put in your mind a scheme for the history taking. and follow this scheme to avoid repetition of questions. So, analysis of the complaint will be first, then ask about obstetric and gynecological history, sexual and psychological history, medical and surgical history, drug and social history, and finally, family history. You can memorize it in this manner: obstetric and gynae history, sexual and psychological, medical and surgical, drug and social, and finally, family. In the obstetric history, only one question: have you ever been pregnant before? Don't lose your time and ask here any miscarriage, any abortion. No, only one question: have you ever been pregnant before? And if yes, ask here open question: tell me more about this pregnancy. And you need to ask about every details of the pregnancy, previous pregnancy, if it's antenatal care or during labor module. So in the OBS, tell me more, have you ever been pregnant before? This will be the question. For the gynae history, we need to ask about three things: the period, contraception, and the cervical smear. And also, open question for the period: tell me more about your period. And if not covered in her answer, ask when was the last one? Is it regular? How often is it? For how long does it last? Any bleeding in between your period? Then ask about contraception. Any contraceptive methods used before? Ask about the cervical smear. Are you up to date with your cervical smear? When was the last one and was it normal? So again, for the gynae history, three questions: period, contraception, and cervical smear. Then sexual and psychological history. Sexual history, don't do it before doing signposting. I will tell her, I know that talking about sex may be embarrassing, but I need to ask some question if you allow. Then ask your question about the sexual history, especially in fertility modules. You need to know details of sexual history. Psychological history is important also, especially in antenatal module and in postpartum module. Then you need to ask about the medical and surgical history. In the medical, only one question: are you physically fit and well? If yes, tell me more about that. In the surgical history, any surgery done before? In the drug history, two questions: are you currently taking any medications? And ask about allergy. Are you allergic to any medications? And if the role player told you that she's allergic, you need to follow that by two things. Ask her what happened when you take this medication, and then tell her, I need to document this in your notes. Then you need to ask about the social history: living, do you smoke, drink alcohol, with whom you live, and is he supportive or not? And finally, the family history. And when you ask about the family history, try to be specific. Let's say it's antenatal care module, so I will ask any family history of diabetes or hypertension or genetic disease. In this task, there is premature ovarian insufficiency, so I need to ask if there is any family history of similar condition in your family. So be specific when you ask about the family history. After finishing your history, say thank you for sharing your information with me. And don't forget that information gathering not only includes history taking, but also it includes examination and investigations if required. So, specific questions related to subfertility module. Remember that we need to ask the patient question in order to confirm that she has infertility and what is the cause of the fertility. So I will start open question: tell me more about your concern. I need to confirm the period of infertility. For how long have you been trying to have a baby? I need to know if any investigations done before. Have you ever offered any treatment before? So ask about any investigation of treatment. Then you need to ask about every factor in fertility. Infertility could be due to ovulatory disorder. So ask about details of menstrual history. And if the period is irregular, you need to ask about the possible causes. So ask about acne, facial hair, to rule out PCO. Ask about discharge from the breast, any headache, any visual disturbance, to rule out pituitary adenoma. Ask about the weight, about symptoms of premature ovarian insufficiency. So by this question, I need to rule out ovulatory disorder as a cause of infertility. You need to ask about sexual history, as I said, but before that signpost, I know that talking about sex may be embarrassing, but I need to ask some question if you don't mind, then ask. How often is the intimate relationship? Any difficulties? Any history of sexual shield infection? Any abnormal vaginal discharge? Any bleeding after having sex? Then I need to roll out tubal factor for infertility. So any surgeries in your tummy or down below? Then do not forget to ask about smoking and drinking alcohol. And if it's positive, give her advice about cessation of smoking and drinking alcohol. Also, you need to ask about exercise, because excessive exercise can lead to hypothalamic dysfunction and can lead to ovulatory disorders. You need to roll out male factor of infertility. So you need to ask about the partner. Take her permission to ask a question about her partner. May I ask some question about your partner? What's his name? How old is he? What does he do for living? Have he ever fathered in a child before? Is he physically fit and well? Is he currently taking any medications? Any surgeries done before, like repair of hernia or undescended test? Does he smoke or drink alcohol? Any concern about his weight? This is the whole question related to the male partner. And ask her also, have you ever been pregnant before or not? And if she answers yes, ask, was it assisted or spontaneous pregnancy? And was it from the same partner or not? Don't forget also to ask if she's taking folic acid. And if she's not received the folic acid, you need to add this in your management plan. I'd like to give you folic acid because this will reduce the chance of new defects. So remember, in infertility, you need to rule out the causes. If it's unexplained, this can be defined when I ask about how long have you been trying to have a baby. If more than 2 years and all investigations and investigation results are normal, so it will be unexplained infertility, and you will offer here the option of IVF. You need to ask about male factor, and usually the male factor, the treatment option could be IVF or even ICSI if there is oligospermia. You may be offer donor insemination. Sometimes you may offer surgery if the male factor of infertility related to obstruction. Medical treatment also could be offered if there is pre-testicular causes like hypothalamic dysfunction. You can offer medical treatment. You need to rule out ovulatory disorders and the causes, as you know, PCO, premature ovarian insufficiency, hyperprolactinemia. So ask about all of those. You need to rule out tubal factor, and usually the treatment will be IVF if there is tubal obstruction bilateral. Or you can offer tubal surgery, but when you told about tubal surgery, you need to tell that this needs to be referred for tertiary center to do this surgery. And also it could be endometriosis, the cause of the infertility, and sometimes it could be abnormal anatomy, which can be determined from the ultrasound. Like sometimes if there is submucous myoma more than 4 centimeters, we can offer myomectomy. Remember also the baseline investigation for infertility. For every infertile couple, we do the baseline investigation in the form of semen analysis, and if abnormal, we need to repeat after 3 months. If severe oligo or azoospermia, we will repeat it as soon as we can. The baseline test also mid-luteal progesterone to assess the Q2 hysterosalpingogram, to determine any abnormality within the uterus, do ultrasound, chlamydia, and rubella screening. This is the baseline investigation. If there is any abnormality, we can add additional investigation, like doing FSH and prolactin, and further investigation for male infertility. So, coming back to the task we discussed, the main point in the station of premature ovarian insufficiency that you need to assess the patient's main concern. Her main concern now is having a baby. Confirm the normal result as Dr. done. She confirmed that she has normal ultrasound on the uterus. She has normal tube. She's immune to rubella. The importance of repetition of FSH to confirm the diagnosis. And that the treatment will depend on her final test, but we need to go through the treatment options. And remember that the treatment options will be for her general health, we need to offer HRT, and for the fertility, we can offer oocyte donation with IVF, or even we can do adoption is an option also for her. Don't forget that station of breaking bad news, and you need to tell her that we need to do further tests in case of you find you have confirmed premature ovarian insufficiency, like in the form of karyotyping or screening for autoimmune diseases. So for premature ovarian insufficiency, the diagnosis will be based on menstrual disturbance for at least 4 months, and the serum FSH level is more than 25 international units. On 2 occasions, we need to repeat the test for a period of 4 weeks at least. So to say that the patient has premature ovarian insufficiency, you need to confirm this criteria. Test is done twice with 4 weeks apart, the age is less than 40, the FSH level is more than 25 international urine collation. Once you confirm that the patient has premature ovarian insufficiency, we need to do further tests in the form of karyotyping, ovarian autoantibody screening like thyroid antibodies, other autoimmune syndrome like antiphospholipid syndrome. You need to assess bone mineral density because she may develop osteoporosis. You need to exclude in your history the iatrogenic causes like ask the patient, is there any history of cancer treatment, radiotherapy or chemotherapy, as it could be the cause. Ask about family history of similar condition. And if there is evidence of Y chromosome, we need to offer the patient the importance of do gonadectomy to reduce the risk of gonadoblastoma. And remember, when you counsel the patient with premature ovarian insufficiency, if she's not seeking fertility, you need to counsel her about the importance of contraception, because still there is incidence of spontaneous pregnancy in about 5% of cases. While counseling this patient, you need to tell her about the implication on her general health in the form of cardiovascular risk, menopausal symptoms, osteoporosis, and the risk of infertility, especially if she's seeking fertility as in this task. Her management option will be hormonal replacement therapy, and the fertility option will be referral to fertility specialist. You can counsel also that we can do fertility preservation if it's still not yet established premature ovarian insufficiency, or side donation with IVF. Surrogacy sometimes could be an option, especially if the patient has, for example, she is a case of Turner syndrome and she has infantile uterus, so pregnancy may not be an option for her, or if she has a medical condition like severe cardiac impairment, which makes the pregnancy risky for her. So still surrogacy can be an option. And as any infertile couple, we need to counsel about adoption. So now if anyone has any question related to this task and related to history taking, please let me know.
Dr. Asha, I have some question. If
Yes.
in the history mentioned, as you mentioned that she has no visual disturbance, no headache, no galactoria, so we should ask again or no need to ask?
Yeah, it's a really good question. Yeah, and you need to confirm that. Don't ask. You need to tell her, I can see that you don't have any visual disturbance, any headache, any milky discharge from breast. To avoid wasting your time, just to confirm that in the task.
So we have to confirm.
Yes.
And the examination, because in the talk article mentioned we will do examination for height and weight and for like hirsutism, acne, but if already mentioned in the history no hirsutism and acne, so that's why not examine. Or she has second visit, so what about examination?
For every case. No, it's not mandatory. You need to examine if you need. If the examination finding will determine your diagnosis, is vital for your diagnosis and management plan. But if it is not necessary, don't waste your time.
Okay. And this you mentioned in the diagnosis FSH is greater than 25. It is 30 or now 25? Is there any change? This is the
In some
new
sources it's 25, in other sources it's 25. But here in the task it's clearly it's about 40. So whatever, it's a high level of FSH.
Yeah. Okay.
And any other question, Dr. Aisha?
No, thank you. And yeah, one thing I want to ask. One thing that ovarian reserve. In Turner syndrome, we have to check ovarian reserve. But in premature ovarian insufficiency, I did not read in that. I did not find in talk article that we should check ovarian reserve.
It's not established. Sometimes she may not have established premature ovarian insufficiency. In the fertility center, they may find that she may have oocyte which could be used for IVF. So you need to tell her about this option.
So we should tell this ovarian reserve we have to check or no in this situation?
You will tell her, I'd like to do referral for fertility specialist. Your option could be either See if you have any option for preserving your fertility or egg donation with IVF or adoption. Just tell her about the options.
Okay.
Don't go through its details.
Hello, Assalamu alaikum, Dr.
Okay.
Rasha. Dr.
Alaikum
Rasha,
salam.
in this scenario, we are already in infertility clinic. So if
Yes.
it is like this, that we are in infertility clinic, still we will say that I will refer you to the fertility specialist, or I
No,
am the
because
one
you
who
are in
is
the
for
situation
fertility
where I
specialist.
will involve my consultant. Only involve with the consultant because you're already in the infertility and it's part of the situation awareness where you are. Don't do referral in the fertility clinic and you are already in the fertility clinic. But remember that you may do referral for tertiary fertility center, not the fertility clinic. You will involve with a consultant, but if she requires advanced treatment like fertility preservation, it will not done for in every hospital. This could need specialized fertility center. So tell her I will involve my consultant and may consider referring you to a specialized fertility center.
So it means like we are in the infertility clinic. So IVF we can do in the same clinic where I'm sitting?
You will IVF. Not every fertility clinic have option of IVF. Have
Yeah,
option of egg
that's why I'm
donation.
telling. That's why fertility IVF not in all the fertility clinics. So that's why we
Yes,
should mention
yes.
that we should refer to the
Yeah, you
fertility
will refer for
specialist
specialized
clinic.
fertility center. Yeah, but
Yeah,
not for fertility clinic. You make
yeah,
you can understand my point. Only for the
yeah, yeah.
fertility center, but not for the fertility clinic because you're already in the clinic.
Okay, okay. Thank you.
Welcome.
Dr.
Any more
Rasha.
questions?
Hello,
Yes.
Dr. Rasha.
Yes.
Hello.
Hello, Dr.
How
Ansar.
are you, Dr. Rasha? We miss you so much.
Thank you, Dr. Ansar. Thank you.
I want to just ask something. Is this female with premature ovarian insufficiency, can if we give her hormone replacement therapy or just to prepare the endometrium of her, could she do the role of surrogate mother?
The role of surrogacy here depends on the cause. Sometimes, if you do carotiding, she may be Turner, and in Turner, she may have infantile uterus. Infantile uterus associated with high risk of miscarriage. So sometimes the surrogacy will be her option. And even you may find that the patient has medical condition which makes the pregnancy risky for her. So at this time, you may offer her surrogacy. So it depends on
Yes.
her final result.
Yeah, I mean, if she is not Turner or if she doesn't have any infantile uterus and for unknown reason premature ovarian insufficiency occurs, can I give her? She could successful as a surrogate mother after HRT.
No. If she has, she don't have any contraindication for pregnancy. Why to offer surrogacy? Only oocyte donation.
If she has a premature ovarian insufficiency, ma'am, and her uterus is normal inside, I could give her HRT to prepare the endometrium to receive the after egg donation and the sperm of her partner to
This
receive
will depend
the
on the protocol of the IVF center. I got your point, Dr. Tsar. This will be determined by the IVF center if they need to give her hormonal treatment before or not. But if she don't have any contraindication for pregnancy, so it's okay to go for her own pregnancy, don't for surrogacy.
Okay, ma'am. Thank you very much.
You're welcome. Any more questions?
Hello, Dr.
Shall
Rasha.
we move? Yes.
It's a general question I have. If the question mentions about semen analysis normal, how do we tell this to the female partner?
Yes, in this situation, I told Dr. Aisha that I know that my husband has normal semen analysis.
Yes.
So
If
I
not,
already
how?
know about this. Do you think that or you will tell her that in the next time we can discuss about your husband's results in the next consultation? Don't disclose
Okay.
without permission, especially
And
if it's abnormal.
okay. And do we need to do this auto antibody screen in this patient after 4 weeks after confirmation of the diagnosis?
Yeah.
Okay. Thank you.
Okay, Dr. Rasha, one last question, doctor.
Yes.
Can you please explain what is fertility preservation if still the diagnosis of premature ovarian insufficiency is not established?
Sorry, I didn't get your point. Can you repeat, please?
I didn't understand this sentence. Fertility preservation should be advised to the patient if the diagnosis of POI is not done yet. I couldn't understand that, doctor.
Yes, because if it's not established, sometimes she may, before she has established premature ovarian insufficiency, if before all of her oocytes have been consumed, she may have remaining oocytes that can be used for IVF. So it is still not established premature ovarian insufficiency, and still there is oocytes that can be used. This can be determined by the IVF center. They can see if she has remaining oocytes in her ovary or not.
Okay, okay. So what are the tests that they do? We need not mention that to her right now.
Sorry?
For fertility preservation, what are the tests they do, doctor?
It's not our level to do what is the test. Just do the referral.
Okay.
Do the referral to the fertility center, and they will see if she have any remaining oocyte in her ovary or not. They can do anti-malarian hormones or sometimes with the FSH, but don't go through these details. You will not have time.
Okay,
And
thank
yes,
you, doctor.
before
Thank
above our competency, you are only registrar. You are not fertility specialized.
you.
Okay?
Okay. Okay, doctor. Thank you.
You're welcome. Any more questions there?
Hello, Dr. Asha. I have one question. This patient can conceive,
Yes.
so you should give contraception. So shall we say contraception or HRT? If she is not found
Sorry,
pregnant.
Dr. Vanita.
Yeah, I said if this patient can conceive in future, and if she is not concerned about her fertility, we should advise her contraception. So is the contraception
Yes.
HRT? What?
Yes, we need to give her contraception, yeah. And
Only
ideally, we give her combined this, no contraindication, to make her have the both benefits of hormone replacement and at the same time contraception.
okay. Okay, thank you.
Welcome. Any more questions? Okay, let's move to the next task.
Dr. Asha, Dr. Rahat here. I just want to confirm that FSH more than 40 is diagnostic for premature ovarian failure. So we need to repeat test again if it is more than 40?
Yeah, need to repeat, but more than 25, not 40, more than 25. If
No,
more than
but more than
25, we need
40, I read it from Due
it's
Hertz
still,
that it's more than 40 is diagnostic of premature ovarian failure.
but still you need to repeat. But because it's very high, you will counsel here about the diagnosis. But still you need to repeat it. But you will tell her that it's unlikely that the result will change. So counsel her about her management options.
Okay, thank you.
Any more questions? Okay, let's move to the next task. Dr. Rahat Barvin.
Yes, doctor.
So the next task is coupled with the first task. It's the same case. We forget to mention about this slide, so rapidly we need to know about the cause of premature ovarian insufficiency, if it's chromosomal or genetic defect, autoimmune disease, chemotherapy or radiotherapy, infection and surgery, but sometimes it could be idiopathic. Family history and smoking is associated. Ask about the medical and surgical history, radiotherapy and chemotherapy. Genetic abnormalities found in about 10%. Do screening for adrenocortical antibodies and for thyroid antibodies. So this is your task, Dr. Rahat. The task assess the following clinical skills: patient safety, communication with patient, communication with colleagues, and applied clinical knowledge. The same couple have returned to the clinic. The consultant is away. Phenotyping has come back as XOXX with a small amount of XY. Turner mosaic. Explain this result to the patient and plan further management with them. You have now 2 minutes.
Yes, doctor. Can we start?
Yes, okay. Remember that you know this patient, okay? It's a couple patient.
Same patient, right?
Okay. So, yes, the same patient, yeah.
Hi, I'm
So,
Dr. Rahat, one of the doctor in the fertility clinic today. Is it Mrs. Sally John?
yes, I am. I am Mrs. Jones.
Okay, Mrs. Jones. How are you doing?
Yeah, I'm fine, doctor. Thank
Mrs. John, as I understand that today you are here to know about the results which were sent previously for you. Is this correct?
you. Yeah, correct.
Any other concerns and expectations from today's consultation?
Yes, I looked up in the internet about premature menopause, and I know that I could use donor egg and IVF. So I wonder if it could be a possible option for me,
Okay,
especially that I
okay,
began to despair about this.
okay. So you have been trying for the pregnancy for last 2 years, is it correct?
Yes, correct.
Okay. Before coming to your reports, I will discuss different points with you. Uh, uh, how is periods is still irregular? When was your last periods?
Yeah, it was 60 days ago.
6 days. Okay. Otherwise, you are fit and well.
Yes, though.
Okay. Yes, Mrs. John, I have your report with me. Has anyone discussed this report with you?
No.
Okay. So your partner is also with you. So is it okay? I will discuss in front of partner means result, or you want to discuss it alone?
It's okay, doctor.
Okay. Uh, uh, Mrs. John, uh, it's first I will confirm that this report belongs to you. This is report of Mrs. Jones with this date of birth and NHS number. Mrs. Jones, I'm sorry to tell you that results are not as it was expected.
What does it
I
mean?
I have little difficult news for you, Mrs. John.
No. What's the problem? What about the results? I get worried.
Yes, your karyotyping which was done, it is showing that you have Turner's mosaics. Have you ever heard about it?
No, what does it mean?
Okay, I will explain to you for you. I will draw it for you. Actually, we have done study to see the chromosomal analysis. Okay, that's called as karyotyping, and we have every means female they have 46 XX chromosomes, but sometimes in what happened in Turner's, rather than XX, this is a 46 23rd pair, but that is X chromosomes. In the sex chromosome, that one chromosome sometimes is missing, that is XO, along with normal. Some cells contain normal structures of the chromosomes, normal number of the chromosomes, like 46XX, but some cells they contain one chromosome is missing, that we called as Turner's mosaics. Is it clear?
Yeah.
Yes, Mrs. John. In this condition that we call as Turner's mosaic, we have to, if someone is keen to get pregnant, before that patient need to seen by multidisciplinary team. Have you ever have any problem like any issues with the heat and cold intolerance or something like that?
No.
Okay, so first thing which I would like to do for you, I will send you to the multidisciplinary team to further your cardiac heart evaluation, because these patients are at risk of certain heart abnormalities. Okay.
Mhm.
Then we'll check your blood pressure, we'll check your height and weight ratio, BMI, and then we will see your hearing test, that is called audiogram. Then we will check your thyroid function test. We will do screening for your how your kidneys are working, how is your liver is working, and for screening for diabetes. And also we'll do ultrasound for your pelvis to see the reproductive organs like your womb and your ovaries, and also we'll do the ultrasound of your renal system, and heart scanning is also required. And then we will check the bone density, means because the one test which is called as X-ray absorptiometry, that test to see the thickness of the bone. These are important screening tests before embarking on pregnancy. Is this clear?
Oh, will I have all of these problems? Problem with my heart, thyroid, kidney, womb, what all of this?
Yes, Mrs. John, I'm sorry that it's a really a difficult news to accept it, but if a diagnosis is like that is in your condition, which called Turner's mosaic, so we have to do all these tests to see because how your all these organs are working. So these tests are important to do before seeking for pregnancy. So if everything is well, is all heart, everything is well, then we can say you are fit for to go for the pregnancy. Is it clear?
So there is possibility that this test may be normal, not necessary to be abnormal. Am I right?
Sorry?
So it is not necessary to have all of these problems. You will just screen for it, and there is possibility that it will be normal.
Yeah, so that's why we have to exclude all these things. Everything is normal. Then it means you will be fit for the pregnancy. Then for pregnancy, then we need to refer you to the fertility center. Sometimes 8% of patients, 8 out of 100, they can conceive spontaneously, but sometimes they need some assisted techniques for the pregnancy.
Mhm.
So after this whole test, I will refer to the fertility center, and for further pregnancy, they will explain to you. Then I will, if you want, I will arrange a meeting with my consultant, and I will also means give you information, written information of your condition, and if you require, I can arrange a counselor from my clinic, and I will give you contact number of my clinic. And then if you want to ask any question anytime, you can come. You are free to come here. You can ask me.
Mhm.
So it's okay. I will refer you to the group of specialists for your all evaluation. So once fit, so you can embark on your pregnancy.
Okay.
And anything you want to ask, Mrs. John?
No, that's it clear. Thank you.
Okay, thank you.
I really just now feel the risk that I will not be able to have baby. I feel it become more complicated. I feel that there is no hope.
No, it's not like that. When I will refer you fertility center, they will check this the your ovaries how they are functioning. Is it I mean, it's normally functioning? Your eggs are enough amount is being produced. Then there good chance that you can conceive it. But if sometimes there is reserve is not enough, it's not good reserve is there, then in that case they will offer you donation for eggs. Egg donors will be there. They will take egg from the donor and the sperm from your husband, and they will do what we call in vitro fertilization. And if your womb everything is fine, then they will implant this embryo in your womb. And but in case if it is you don't want donors egg, then they will give you, means you have option for adoption. You can also go for that.
Mhm.
Yeah. So these are the options which are available. So
Okay. So close the station.
Yes, I will give you written information. I already told you, and I will write arrange next meeting with my consultant. If you have any queries, questions, you can, and then I will refer to the concerned doctors.
Okay. Time's up. Thank you, Dr. Rahat. So you did it well. Thank you for this. And you confirmed from the start the aim of the consultation, and you fixed that there is no domain of information gathering, so you don't lose your time by asking about the history. And you confirm the name and the NHS number in her investigations. You explain well about Mosaic Turner. You involve the NDT and you talk about who will be involved in the NDT. You tell her about the need to check her heart, thyroid, kidneys, uterus, home. You give her patient information leaflet and support group as well. So coming to what would be added to this, you need first, as it's written in the station, the consultant is away. It's a part of situation awareness. You need to tell her that, take her permission that I'd like to see you on behalf of my consultant, because the woman is expected to see the consultant, not the registrar. So take her permission to start the consultation. Okay, this is part of the situation awareness. That's why I told you read the task carefully. Every word in the task will have meaning, and you need to transfer this while doing the station. Then you need to confirm that you know that she has been diagnosed with premature ovarian insufficiency. Ask her about how she's coping. How have you been since your last visit? How did you cope with your diagnosis? Have you been offered any meeting with a counselor? Have you have access to support group? So ask about how she's doing since the diagnosis. Especially that I told you that I don't have hope, I feel depressed. So you need to offer me help, offer me support, offer me meeting with counselor. Okay? And also, when counseling her about the implication of that diagnosis to her condition, don't tell her that there is a possibility that, we need to check the heart, you need to make it more sensitive. Tell her that in most women who have Turner mosaic, usually they will not have any associated abnormality, but we need to screen for other associated conditions, like problem with the heart, with the bone, and so on. But there is a possibility that you may have normal, because you told me that you will have problem with the heart, with the kidney. So the way you tell me, I feel that you complicate the case for me. You tell me many bad news on the same station. So just tell her we need to screen for further complication or implications to make sure that you don't have them. But it is not necessary to have the problem with the heart and so on. The other thing that you missed and our candidate tell you about is the Y chromosome. Don't forget this. It's a very important point of safety. If there is Y chromosome, you need to offer here removal of the gonads to avoid the risk of gonadoblastoma. And also, don't forget about the patient information leaflet when you seek or when you tell her about the diagnosis from the start. You have a condition named Mosaic Turner, and by the end, I will give you patient information leaflet about that. Okay, Dr. Rahat? Apart
Yes,
from
doctor.
that, you did it very well.
Dr. Rasha, how to explain Turner mosaic? How to tell to the
I'm going
patient
to
what's
that.
this?
Yes, I will go to that. So coming to the important point in this station, as I said, you need first to take the permission of the patient that you need to see her on behalf of your consultant, because it's written the consultant is away. You need to confirm that she has premature ovarian insufficiency. I just understand that you have been diagnosed with premature ovarian insufficiency. That's right. I know it's a difficult time for you after being informed about that diagnosis. How are you coping? Did you meet a counselor? Be empathetic with your patient. Then you need to ask if she had any idea about the result of the genetic makeup. Then you will confirm her name, her NHS number, and then ask if there is someone she needs to involve, because you are going to give her more information, because still it's a big and bad news. Then how to explain mosaic Turner to the patient. So to do that, you will do it in 3 steps. The first step, you will need to explain what is normal genetic makeup. Then what is meant by Turner syndrome. And the final step is what is meant by mosaic Turner. So simply, I will tell her First, I will need to explain for you about the genetic makeup, which is made of 46 chromosomes. They are arranged in 23 pairs, and the last pair is the 6th chromosome, and it will be XX in most women. So now I tell her about the normal karyotyping. For most women, they will have 23 pairs of chromosomes. The last pair is the 6th chromosome, and it will be XX. But occasionally, women will have only one chromosome in all cells, while the other X chromosome is missed. And here the genetic makeup will be 45XO, and this is named Turner syndrome. Then finally, I will tell that some women with Turner syndrome will have the genetic makeup of XO in some cells, while other cells will have the normal XX pattern, and this is named mosaic Turner. And it could be associated with a small amount of XY pattern in other cells, as in your case. So now I tell her about what is the meaning of mosaic Turner. Take her through the normal typing, then what is the meaning of Turner syndrome, and finally what is the meaning of mosaic Turner. So after telling her about the diagnosis and offering her leaflet and support group, you need to discuss the implication of that diagnosis on her fertility and on her general health. And as Dr. Rahat mentioned, it's important to mention the importance of MDT, involving the gynecologist, endocrinologist, doctor of genetics, fertility specialist, and cardiologist. And tell the role players that for your general health, we need to check your blood pressure. We need to assess your cardiac functions by doing a ultrasound on your heart, because sometimes in patients with Turner syndrome, they may have narrowing of the aorta, and you can draw this for here. This is named coarctation of the aorta. We need also to scan the kidney, because sometimes there may be associated abnormalities in the development of the kidney. And because in your condition we have element of Y genetic makeup, we need to do an operation to remove your ovaries, because if we leave it, unfortunately, there will be a risk of developing sinister cells, which is named gonadoplasma. This is about her general health. I tell her about the heart, about the kidney. You can add about thyroid, whatever you need to do screening, and this will be determined further by the endocrinologist. And don't forget about the gonadectomy because of the presence of Y chromosome. Then coming back for her wishes, she wanted to have baby. So for fertility, as we said, we need again to check if still you have any ovarian reserve that can be used for the IVF, or you can offer egg donation, or adoption still could be an option. And remember that sometimes in patients with Turner syndrome, pregnancy sometimes will not be advised, because she may have infantile uterus, and she may have also impaired or decompensated heart functions, which makes the pregnancy risky to her health. At this time, you can offer here also surrogacy. And don't forget the importance of Turner support group and patient information list. Any question related to this task?
Dr. Rasha, please.
Yes.
You said, ma'am, that for fertility we need to check for any ovarian reserve or IVF with donor oocyte. This sentence, this is in case of the second FSH below 25, or if it comes again above 25. Any rule for detection of any ovarian reserve?
Although it's a low risk or a low incidence that you may find ovarian reserve, but don't lose hope with the patient. Tell her that still we can see in the fertility center if you have ovarian reserve that can be used in the IVF. It's a small incidence or small chance to find that, but still they will search for that.
Then come to the next question, ma'am. For gonadectomy, if we find an Y chromosome, still we will search for ovarian reserve, or we will proceed directly to gonadectomy?
all will be done together. If you found that the ovarian, there is ovarian reserve, you can do you can even do preservation of embryo or embryo freezing and then go for gonadectomy. And even this also will be determined by the fertility center. If she have reserve, will be done first. If we proceed first with IVF, if we find reserve or there is no reserve, so go first with gonadectomy.
Okay, yeah, that is to say, it is the issue of the fertility center specialized. Yeah, it is not ours. I will give her the options and she will choose for it.
Yeah, that's exactly. You will do her referral and here they will counsel her about all of her options. They will discuss her every option with risk and benefit to select what is suitable for her.
Okay, ma'am. Thank you.
Welcome.
Dr. Rasha, I have one question.
Yes.
When we diagnosed here, she is Turner mosaic. Should we ask about general health, like she has any high blood pressure or any dyspnea or difficulty, any cardiac status, or because there is no information gathered?
It depends. If it is because in this task it's coupled with the previous task, so you know that she don't have any medical condition, so don't ask again, especially that there is no information gathering. But if it comes with no information gathering, but you feel that this question is vital for your diagnosis, yeah, you need to ask. But because in this task it's coupled and you already know that she's medically free, don't repeat the question.
Yeah, yes, you are right.
Dr. Rasha, we will offer an examination in this condition just to detect if any gonads are present or like.
Will it differ in your management? It will
Please
not
offer
give you
her
any difference.
examination. Or
you need to check her blood pressure. This is what you need to do, yes. You need to check her blood pressure. Measure the blood pressure in both arms because sometimes you may find that you have a finding of examination in the blood pressure. She may have high blood pressure in one arm. So this is in case of coarctation of aorta. So at least check her blood pressure.
Means if patient comes, information gathering is not present in the task, then we can do examination. Like in her case, we have to examine her for the detection of gonads.
Dr. Rahat, here gonads mean streak ovaries. This is not like androgen insensitivity syndrome, that testicular inguinal hernia. It is ovaries, but streak. These are the, I think, contain why or what?
No, Dr. Rasha, gonads means what? Gonadectomy means which organ want to remove?
Yeah, this is
Ovaries.
Ovaries, yeah, this is the
removal of the ovaries, yes.
Ovaries need to remove.
That's why I'm telling this gonads mean streak ovaries. So streak ovaries contain this Y chromosome, not like androgen insensitive. They have inguinal mass and this we have to remove undescended testes. No.
Fertilization syndrome, don't mistake. Yes. And even if, as we mentioned before in the gynae module, when we take the patient about gonadectomy in testicular feminization, don't tell her testes. You will say you will remove the 6 organs. Avoid the word of testes.
Means if patient has genetic makeup of XY, so in that case we have to remove ovaries, XO, XX, XY. So then why we are sending her to infertility center to check for ovarian reserve? It means after removal of ovaries, straightforward she will go for this egg donation or adoption.
You are not the one who will determine that. After you do the referral in the fertility center, they will counsel her about her option with risk and benefit, and she will decide. After see if she have already reserved or not. You just do referral and tell her about the options.
And even androgen insensitivity syndrome, we do not remove gonads immediately. Like we refer to fertility specialist center, they can check ovarian reserve, or if find Y chromosome, then they can do gonadectomy.
Yeah.
So I mean, still they can check ovarian reserve. No need to go for immediately for surgery.
It's not immediately because you don't have now any sinister cells. You will screen for that. You have Y chromosome. You will do the surgery, but you don't have any problem now. So it's not urgent. But you will do that. But still, she's taking fertility. So everything will be with risk and benefit after counseling her Do you got my point?
Means later in life, once if
We need to
refer
remove
to
ovary
fertility
from
center.
the rest of semester cell development. But still, she's seeking fertility, so we will refer you for the fertility center to see your options.
Okay. So after fertility center, we will get an option also. Then her gnats will be removed in the future.
My advice for all of you, try to be simple in the exam. This is not your role. Don't sophisticate things for
Dr.
yourself.
Rasa,
Don't do the hill and go through it. Only be clear about the main options. Don't go through its details. It is not required in the exam. You got
Dr.
my
Rasa,
point?
can I speak something?
Yes.
Dr. Rasa, if there is Y chromosome, we need to remove the gonads because there is risk of gonadoblastoma. In
Yes.
androgen insensitivity syndrome, we wait because we want the process of that puberty and the bone development to take place. That is at 15, 16, and after that we can remove. But once she has achieved it, we need to remove.
Yeah, and we already did a previous station about testicular feminization. You can check it again. We did it before in the gynae module.
Thank you, doctor.
Any more questions? Welcome. Shall we move?
Dr. Rasha, can you show please the previous slide just for a few minutes?
Okay, so Dr. Nurmeen Khan. Dr. Nurmeen?
Yes, Assalamualaikum.
Yeah, alaikum salam.
Can you hear me, Dr. Rasha?
Yes.
Okay. Okay.
So this is a structured discussion task aimed to access the following domains: information gathering, applied knowledge, and patient safety. In this station, you will go through a brief summary of patients and investigation carried out. You will be expected to interpret and discuss each scenario and give your management plan. Any answer given retrospectively will not count toward your final score. In this task, you will have 4 parts of which. The first part, 36-year-old lady presents from accident and emergency with worsening abdominal tension and pain. She had an inferior transfer 3 weeks ago at a private CVS center and she has reported pregnancy. Take your time, 2 minutes, and then tell me about your differential diagnosis and your report.
Dr. Rasha,
Yes.
you will provide the record, ma'am.
Sorry?
You will give us the record, ma'am.
The record, yeah, it's recorded.
Okay, thank you, ma'am.
Dr. Naveen, there is some noise from your side. Can you
Oh, I'm
please
sorry
calm
because
down?
I'm in the hospital. I'm just trying to move from
Try
there.
to find the suitable place, yes.
Yeah.
Can you start?
Hello, I'm Dr. Noreen. Hello.
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 Yes. Yeah, you read the scenario?
Hello, I cannot hear you.
Yes, you read the scenario? Yes, Dr. Noreen, can you hear me?
Hello. Oh my God.
Dr. Noreen?
Hello.
Yes? No voice for everyone or only for you? Is my voice clear?
Yes, your voice is clear.
Dr. Noreen, I think the problem is from your side. Dr. Noreen? Dr. Noreen? You can't hear. I think there is network problem with you. So do you want to postpone your station? Dr. Noreen, you want to postpone your station until you set your net connection? Okay. Okay, Dr. Noreen. So Dr. Fawzia, yes? Dr. Fawzia? Dr. Rajhi Agrawal? Dr. Raji? Dr. Jagofta?
Yes, Dr. Raj.
Dr. Shagofta? Yes, well.
Yes.
Are you ready to start?
Yes, can I read the scenario, ma'am?
Okay, take 2 minutes. Okay.
Yes, Dr. Raj, I'm ready.
Okay, let's start.
I'm Dr. Shagupta, one of the exam candidates. I have read the scenario and I'm ready for the structured discussion.
Okay, so what's your differential diagnosis?
So, as this is a case of a 36-year-old lady who has presented with abdominal distension and pain, and in the background, she had an embryo transfer 3 weeks back after IVF in a private IVF center, and she also has a positive pregnancy test. So, my differential diagnosis in this case, I would like to assess the patient. I would like to take history and also examination and investigation of the patient, and then my differential diagnosis will be based on that. So in this case, my differential diagnosis is first is ovarian hyperstimulation syndrome. Then the second differential diagnosis is an ectopic pregnancy, and the third differential diagnosis is it can be due to an ovarian accident like ovarian torsion or ovarian torsion. Yeah.
Any
And
other?
also it can be due to it can be impending miscarriage.
Yeah. Okay. So after assessing the nature of her abdominal pain, you suspect that it is a case of ovarian hyperstimulation. What specific further question you'd like to ask?
So I'd like to ask her about her. I would first introduce myself and explain my role to her, and then I would like to ask her about her history of present illness, like because she has abdominal distension and pain. So I want to know how is the pain, what is the intensity of the pain, and is it associated with is it associated with vomiting, and does she also have any difficulty in breathing? Then what about her? Is she passing? Is she passing urine normally, or is she passing small amount of urine? And also, I want to know about her distension. How severe it is, and is she able to take keep? Does she have vomiting? Is she able to keep anything down? Then so this is what I'll ask in the history. Yeah.
Any other questions you'd like to ask?
Also, I would ask her whether she's taken any treatment for this, and where did she have the fertility treatment? She had in the private fertility clinic, and when was the embryo? How many embryos were replaced? And when the I want to know whether the trigger injection was given or not, and also I want to ask about any medical condition she has. Is she taken well to rule out if she has any background of polycystic ovary, and then I want to know about any surgery she's had because surgeries may be associated with adhesions and they may increase if she has had any surgical complication, then the surgical risk increases. Then I want to know about allergies because I may need to prescribe certain medicines to her. Then also I want to know about her, her support at home, and also her other high risk factors like whether she smokes, drinks, or takes any drugs. And also I want to know about her. I want to know about her.
Okay, doctor. So what investigation would you request when you view this lady?
So first of all, I want to know about her. I want to examine the patient, and investigations. I would like to take her full blood count, including hematocrit, and also I would.
What do you mean by examining the patient?
What investigation? Examine the patient. When I examine the patient, I want to examine her pulse, blood pressure, temperature, her respiratory rate. Then I would measure her abdominal girth. Also, I would like to know about her weight, and then I would do certain tests for her. Like I want to do full blood count and hematocrit, including hematocrit. Then I want to do liver function test and kidney function test to see how the kidney and liver are working. And also I want to do a ultrasound I want to measure the size of the ovaries, and I also want to know if there is any ascites. And also I would like to do a coagulation profile because this OHSS predisposes to clots venous thromboembolism. So I would like to do a baseline coagulation profile for her also. Also, I would do a urine examination to see, the level of dehydration. There are any ketones in the urine.
Okay. So investigation supports diagnosis of moderate ovarian hyperstimulation syndrome and she's being managed as an outpatient. What would trigger admission to hospital?
Okay, so the trigger of admission, I would tell her about all the red flags. I would tell her that if she has any difficulty in breathing, if she has any chest pain, if she is not able to keep anything down, if she has persistent vomiting, and if there is increasing abdominal distension, and if there is any, if the pain is not getting better with the medicines which we prescribe, then she has to report to the either to the accident and emergency or to the fertility clinic or to the GP. Also, if she has any swelling in her legs, or any pain in her legs, that is also a red flag, and she has to immediately report.
Any other indication for inpatient admission? Okay, would you like to add anything?
I would, I would tell her that she has to, if she has any trigger, if she has any red flag, then she will be admitted, and then we'll give her hydration with IV fluids, and also do her hematocrit and liver function test, kidney function test. Every alternate day, and also we'll give her pain relief. We'll give her analgesic and anti-emetic, and also BP prophylaxis.
Anything you'd like to add?
If she's, if she's undergoing outpatient treatment, then I would also advise her to avoid sex and any strenuous activity. And also, I would tell her that she has to avoid non-steroidal anti-inflammatory drugs.
Is there from your investigations any indication for hospital admission from the investigation results?
So if the hematocrit is more than 45, then she will require hospital admission. Or if the creatinine is on the higher level, or if the WBC count is more than 25,000, then she requires hospital admission. And also, if in the ultrasound there is trench ascites, then she will require hospital admission.
Okay. Okay, Dr. Jacobta, still we have 40 seconds, and this also will be the same case in any Bible station. You will have remaining time. But if you have any remaining time in the station, don't repeat yourself. Read the questions again, and if you find that you can add any specific points, add it, but don't repeat yourself. Thanks for sharing, and you did very well. You covered already most of the points. So let's do it again.
So the first question I forgot to ask about the previous obstetric history, whether she's had any other fertility treatment, and whether she has previous history of any ovarian hyperstimulation syndrome. And also, I would like to know about, I want to know her age also, because age is also a risk factor if she's under 30 years old, and that is also a risk factor for OHSS. And so this is, I want to add in the history this thing.
Okay. Take care that in private station, you should usually you will not be allowed to go retrospectively. So don't move to the other question unless you are sure that you already answered the first one. Because sometimes the part 2 and part 3 will give you information that if you made the total in the first part will not be counted for you if you mentioned it later. So don't move unless you are sure that you are ready to move. No other data I'd like to add. But here in this scenario, you can add because it is not coupled, not related to the next part. You can move between the parts still if you have time. But in other scenarios, in the vital station, you cannot come back to the previous question if you decided that you need to move to the next question. And in the vital, you will have time, so don't be in panic. Answer clearly and make sure that you said what you need to say about these questions. Okay, Dr. Javatta, however, you did it very well. You covered most of the items. So the first part of this question, you welcome. The first part of this question is what's your differential diagnosis? So in this case, from the data, it's a patient who is coming to the A&E department with acute abdominal pain, and there is a history of imperial transfer 3 weeks ago in a private center, and she's pregnant. So the first thing you will come in your mind is ovarian hyperstimulation, and it could be ectopic pregnancy and ovarian accident, as you said, ovarian torsion and cyst rupture. But don't forget also that sometimes she may suffer infection following embryo transfer and egg retrieval. So you need also to put in your differential diagnosis pelvic infection and abscess, and but also general cause of acute abdomen like appendicitis. So add to the differential diagnosis pelvic infection and appendicitis. The part 2 is after assessing the nature of her abdominal pain, you suspect that she's a case of ovarian hyperstimulation. What is specific further question you'd like to ask? And it's a specific question. Don't go through all the items of the history taken. Be specific for the diagnosis. She has moderate hyperstimulation. So I will ask myself that from the question I'd like to ask, I need to determine the risk of this patient who lead to this ovarian hyperstimulation, and I need to ask a question in order to categorize if it's mild, moderate, severe, or critical. So I need to ask about the time of onset of symptoms to determine if it's early onset or late onset ovarian hyperstimulation, because in late onset it will be associated with worse prognosis. I need to ask what is the treatment used for triggering, if it's HCG or GnRH agonist, because induction by GnRH agonist increase the risk. If a woman is high risk to develop ovarian hyperstimulation, like if she's a case of PCO, usually the induction will be by GnRH antagonist. They will follow the antagonist protocol. I need to know about the number of follicles on her final scan, because if the number of follicles is more than 16, it's also a risk factor for ovarian hyperstimulation. I need to know about the number of eggs collected and how many imperials replaced. If she is a known case of PCO, if she has a past history. So all of these questions are aimed to determine the risk factors of ovarian hyperstimulation. Then I need to ask about the symptoms of ovarian hyperstimulation, starting from nausea and vomiting. So it will be between mild and moderate ovarian hyperstimulation. Then I need to ask about complication symptoms. She may develop RDS, so I need to ask about restlessness. She may develop renal impairment, so I need to ask about the urine output. She may suffer edema, so I need to ask if there is swelling in her leg or vulva. She may develop DVT, so I need to ask about thrombosis, if there is severe pain in her leg or shortness of breath. All of these need to be asked. This is a specific question. Ask about the risk factors and symptoms to determine what category of this ovarian hyperstimulation, whatever it's mild, moderate, or severe, or critical. The third part is what investigation would you request when you review this lady? You need to examine the weight and the birth, and because this will be monitored during her follow-up to see if there is any build-up of fluid in her body. You need to do full blood count, and when you are in a vital station, when you said that I order investigation, please explain why you need to order this investigation. So I need to do full blood count to check for anemia and raise the hematocrit, which suggests ovarian hyperstimulation. I need to order urea electrolyte to check for renal failure and hyponatremia, which can occur with ovarian hyperstimulation. I need to check the CRV because it can guide for the severity. I need to check for the osmolarity because this is associated with hypoosmolarity. I need to check the liver function. May I find raised enzyme and low albumin, which could be a complication of ovarian hyperstimulation. I need to check clotting by doing fibrinogen and antithrombin. And I suspected if it's severe or complicated, I may find elevated fibrinogen and reduce the antithrombin. Here she is pregnant, so no need for serum HCG, but I need to do ultrasound in order to make sure of the location of the pregnancy, make sure that she's not ectopic, make sure that she's single pregnancy, not multiple pregnancy, see the viability of the baby, assess the size of the ovaries, and see if there is a sign. This is the basic investigation. If the patient has further symptoms which indicate complication, like if she has symptoms of DVT or pulmonary embolism, may I order further investigation like CT, pulmonary angiography, and ventilation, perfusion, lung scan. So don't forget that once you mention the investigation, try to explain why you need this investigation. Will account for the seeking for anemia or raised hematocrit, and so what investigation and why I need to order this investigation. The last question is, the investigation supports the diagnosis of moderate ovarian hyperstimulation and she's being managed as an outpatient. What would trigger admission to hospital? If the patient is unable to achieve satisfactory pain control, it's an indication for hospitalization. And if it's a role player, don't forget to tell her that you can control your pain by taking paracetamol and avoid taking medications which contain substance named non-steroidal, like ibuprofen product, because this carry a risk of renal injury. And if your pain is not controlled, you need to seek advice immediately, because it could be an indication of accidents. She may suffer from torsion or rupture of the ovarian cyst. So if the patient don't have satisfactory pain control, it's an indication for admission. The other thing is, if the patient is unable to maintain adequate fluid intake because of nausea, so you need to admit her and give her fluid replacement. If the patient showing worsening ovarian hyperstimulation, remember that ovarian hyperstimulation syndrome is dynamic process. You may see the patient today with mild symptoms, and within hours she may deteriorate to severe or critical. So if she develops any of the following symptoms: increased abdominal distension pain, shortness of breath, tachycardic, hypotensive, reduced amount of urine, weight gain and increase in abdominal girth, hematocrit more than 0.045, it's an indication for hospitalization. If the patient is unable to attend for regular outpatient follow-up, so admit her. If there is any signs of critical ovarian hyperstimulation, like tense ascites, large hydrothorax, hematocrit more than 0.055, white cell count more than 25,000, olivoric, anoric, thromboembolism, ARDS, all this indicate critical, which is an indication for hospitalization. So remember that in ovarian hyperstimulation, during the stimulation of the ovaries, the ovary responds with hyperstimulation and release vasoactive substance, which is named vascular endothelial growth factor. This factor leads to shift of fluid from intracapillary to the surface space. And as a sequence of that, the patient will have edema, and it could be in the form of ascites, hydrothorax, lower limb edema, vulval edema. And as a result of shift of fluid from the intracapillary space, she will have hypovolemia. And because of this hypovolemia, she may suffer impairment of renal and liver function, and she develop complications in the form of renal failure or liver impairment or RDS. And also, as a result of hypovolemia, she will have hemoconcentration, and she may develop thromboembolic complications. Don't forget about the classification. It's very important to know it correctly, who is the mild, who is moderate, who is severe, and who is critical. And remember that mild ovarian hyperstimulation, only the patient has pain and bloating, and she has a small ovarian size less than 8, not more than 8 centimeters. While in moderate, she started to develop nausea and vomiting. And in ultrasound, you will find that the ovarian size increased up to 12 centimeters, and you can see evidence of ascites. If it is the case, it's a moderate ovarian hyperstimulation. When she's severe, if she has clinical ascites and sometimes hydrothorax, if she develops oliguria, if hemoconcentration more than the hematocrit more than 45%, if she develops hyponatremia, if the ovarian size is more than 12 centimeters. This is severe ovarian. While the critical, if there is tense ascites or large hydrothorax, if the hematocrit becomes more than 55%, if white cell count more than 25,000, if she's oligoanuria, thromboembolism, develop ARDS. Remember also that if the patient is admitted, what you will do during the admission, because sometimes this scenario may come in role player. So you will counsel here what you will do in the admission. So daily you will follow the weight, the abdominal girth, fluid chart, hematocrit and electrolyte, liver and renal functions. And if she has further symptoms, you can order further investigation. Do not forget to counsel the patient about the analgesic, and remember the analgesic. Two things you need to counsel the patient: that avoid steroidal anti-inflammatory agents like ibuprofen, and if you see severe pain, if you develop severe pain, seek advice immediately, because it can be an indication of torsion or ectopic pregnancy. Don't forget the importance of fluid balance and thrombophylacsis, especially if the patient is admitted to the hospital. Paracentesis only indicated if there is tense ascites or if there is severe pleural effusion, and only surgery is indicated if there is accident in the form of torsion or ectopic pregnancy. And in the patient is developed critical ovarian hyperstimulation, don't forget the importance of MDT and intensive care admission. Okay, we finished. If anyone have any question, let me know. Any question related to this case?
Hello.
Yes, hello.
Yeah, actually, I want to ask Dr. Asha about the first question. When the question is, what is the differential diagnosis? So normally we start with summary and then we come to the differential diagnosis. So how we should start it? Like we should just enumerate the differential diagnosis and we will say that we to know more about this, we will ask this question. Or like we have to start with the summary, then say differential diagnosis.
Always start by the summary. Always start by summarizing the case. Then answer according to the question. The question is, what's your differential diagnosis? So only mention the differential diagnosis. But you can explain why you think about that. Simply like she may be ovarian hyperstimulation because she had IVF and she had embedded transfer recently. So it could be also ectopic pregnancy because she is pregnant and she has acute pain. She could have ovarian torsion and cyst.
So, but we have to summarize the case before and then we have to start with differentials, right?
As a complication following, yeah, no, this diagnosis. Am I clear?
Yeah, thank you.
Any more questions? Wait.
Thank you, Dr. Asha.
Shall we move? Yes? Yes, Dr. Shagota?
Yes, I said thank you for letting me perform, Dr. Asha.
Sorry?
Thank you for letting me perform, Dr. Asha. Thank you.
Thank you, Dr. Shagota. You did it very well.
Thank you.
You're welcome. Shall we move? Any more questions? Okay. So, Dr. Fawzia, yes? Dr. Fawzia? Dr. Nurween? Dr. Rashki Agrawal? Dr. Nandita Sanyal? Dr. Nandita?
Yeah.
Yes. So this is your case. The staff assess the following clinical skills: patient safety, communication with patients, information gathering, and applied clinical knowledge. You are an ST5 doctor and about to meet a 40-year-old lady with a history of previous 3 cesarean sections. She started a new relationship and requesting reversal with sterilization. Please take brief history and counsel her about management options. You have now 2 minutes.
Can I start?
Yes, it's okay.
Yeah. Hello, I'm Dr. Nadita, one of the doctor in the gynae clinic today. May I check your name and age, please?
Yeah, my name is Sophie Daniel. I am 14.
Pardon, I didn't get your name.
I'm Sophie Daniel.
Sophia. Sophie. Okay. How may I call you?
Sophie is fine.
Okay. So Sophie, as I come to know that you are here to discuss about the reversal of your operation. So is that right?
Yes, right.
So what is actually your concern? I mean, can you just tell me what is your concern today?
Yes, because I start a new relationship and I'd like to have another baby. That's why I'm here to request reversal of sterilization.
Okay, Sophie, is it okay if I ask you a few questions and then we will discuss your concern, and then I will also we will come to the mutually agreed plan, and then I'll also give you some information if like how does it sound?
Yes, fine.
Okay, so can you just tell me in your how many times you were pregnant before?
Sorry?
How many times you were pregnant before in the in your first relationship?
As you can see from my notes, I have previous 3 cesarean sections.
Okay, and and any miscarriage?
No.
Any other? Okay, and with your permission, I would like to check your notes. And
Why?
do you can you just tell me what type of operation was done for you?
Yeah, I think it was clip.
Okay, and how old is the last child? I mean, how many years have passed after the operation?
Yeah, my little boy is now 4 years.
How 14? Okay,
4
and
years.
4 years.
4 years, yes.
Okay, and any complications in your previous operations?
Yes, in my last cesarean section, they told me that it's necessary to do the sterilization because further pregnancy may carry risk to my own health. But later on, I read through the internet and know that women can have many numbers of cesarean sections, and it is not necessary to do the sterilizations. That's why I think it's better to do the reversal, and it will be safer for me to have another chance for pregnancy.
Okay, so we will discuss that in a minute. Can I ask you when was your last period?
It was 2 weeks ago.
And how is your periods? How many days
It's
it lasts?
regular.
And how often it comes?
My period is regular, occurring every 30 days, and it lasts for 4 days, and there is no issue with it.
Any other medical problem for which you are seeing GP?
No.
Any allergies to any medicine or any anything
Yes,
else?
I'm allergic to penicillin.
Okay, so I will now note it down in your notes. Okay, and any other surgeries apart from these cesarean sections?
No.
Okay, and may I ask you something about your partner? What is his age?
He's 35 years.
Okay, and did he fathered any children from his previous relationship?
No, he didn't have any children. That's why I'm keen to have a baby with him.
Okay, and any test has been done on him?
No.
Okay. So we will have to do his also semen analysis. Okay. Okay, and any family history of concern like sugar, high pressure?
No.
Any clots? Okay. And with whom you are staying?
With my partner.
And how is the support?
Yes, very support.
And Sophie, I would like to ask you, do you smoke?
No.
And do you drink alcohol?
No.
Any drug for fun?
No.
And in the last 3 weeks, in last few weeks, couple of weeks, did you feel down, depressed?
No.
Okay. And I know your height to weight ratio.
It's normal, about 24.
Okay. So thank you, Sufi, for giving me all this information. Do you want to add anything?
No.
Now I would like to examine you in the presence of a chaperone. My nurse will check your blood pressure and pulse, and I will check your tummy and see how the scars are. Is that okay with you?
Yeah.
Coming to the concern, this opening of your previous operation, since you have applied a clip, first thing you have to see how much the length of the tube is remaining. Like I'm drawing you. This is the uterus, and these are the tubes. These are where the clips are applied. So we have to just check how much the length is available for the operation. Also, we have to also check, as I already said, that your partner's examination also has to be checked. If his reports are not normal, then maybe the pregnancy will be difficult for you. Okay. Also, opening this tube does not guarantee that you will conceive, and also there is a chance that even if you conceive, the pregnancy will not be in the womb. It may be outside in the tube. Also, that for cesarean, since you had a problem in the earlier cesarean section, so this time also the chances that the cut which we have given may open up, or the afterbirth may get attached, or there may be some problem with the pregnancy. Like there, it can be a pregnancy which may be into your scar also. Also, there is a chance, since you are now 40 years, there is a chance that there are some genetic, some abnormal. Have you heard about Down syndrome?
I already discussed this risk about my age with my GP.
Okay. And and also this operation will not be funded by NHS.
Why? Why not funded? I don't have any financial support to do it in private, and I know that in private it can cost many money. It's expensive. I can't do it. I want it to be funded by the NHS.
Yeah, because you have got 3 children in the house, and also your age is 40 years, so it will not be funded by NHS. Anyway, we can write down to GP, so he will check.
But I can't do it in private setting, doctor. I need to do it supported and funded by the NHS. I can't do it. I don't have any financial support for that. And I really need to start a new, to have a new baby because my husband don't have any children before.
There are other options also for you, Sophia. You can go for adoption also.
No,
Okay?
I don't think about adoption. It's my right to have my own baby.
Well,
I think it's not necessary to do the sterilization during my last cesarean section. They conceived me to do this. They told me that future pregnancy will be risky, but I discovered that it is not the case. I can have future pregnancy. I can have more than three cesarean sections. So it's my right to do reversal.
Yeah, that is okay for those people who do not have any problem in the last season section. We will also check with your notes what was the problem, whether there was a complete opening of your previous scar, whether there was some, the uterus did not give way. All these things we have to check. Okay, and we will be giving. I'm writing to the GP for inquiry about the clinical commissioner group and about the funding of your IVF. Okay, and I'm also giving you this patient information leaflet, and I'm booking another consultation with my fertility expert, also with my consultant. And okay, anything else you want to know from me today?
No. You'd like to add anything, Dr. Nandita? Any other thing you'd like to add?
Well, I don't think I have to add anything. Thank you.
Okay, thank you, Dr. Nandita. So you did well, and from the start you set the aim of the consultation and put your agenda. And important question you asked about the type of the operation, what type of sterilization she did, and the time passed since the sterilization. And you ask her about the allergy, and you document the allergy. You tell her about the risk of ectopic pregnancy if she does the reversal, and the risk of pregnancy at the age of 40, and the risk associated because she has previous cesarean section, so there is no guarantee for success of this reversal, and there is the risk of complication. You did very well by covering all of those points. Coming to what I'd like you to add to your performance is when you introduce yourself, don't say I am one of the doctors in the clinic. Tell her your role, because the patient wanted to know who you are. Are you a registrar? Are you a junior doctor? Are you a consultant? So it's written you are an ST5. So when you introduce yourself, tell her, hello, my name is Nandita, the registrar in the fertility clinic today. So tell her about your role. Okay?
Yeah.
And also, if there is information written in the task, it's written that she has previous cesarean section. So don't ask me, do you have any previous pregnancy, any miscarriage? Confirm that. I can see from your notes that you had previous cesarean section. Is that right? To avoid sometimes the role player may tell you, you see in my notes that I have previous cesarean section. Why you ask? Okay? Also, try to be more confident when you counsel the role player. I feel that you are hesitating. Sorry for that, but try to be more confident.
Yeah.
Trust yourself. Okay. And also, when you do history taking, don't mix this with a management plan. You asked me about the partner, and you asked if your partner did any semen analysis before. I told you no. Don't give me point of management now. You are now only taking history. During the management, you will tell her that we need to do semen analysis to make sure that your partner don't have problems.
Yeah.
But not now during history taking. Don't mix it up.
Okay.
Other issue is regarding the allergy. You said we need to document this, but try to ask her also what happened when you take penicillin. You need to determine what type of reaction, because you know sometimes simply the patient may develop abdominal pain until they tell you that I have allergy to penicillin, and you will reach the degree that you need to give the patient type of medication which she mentions that she's allergic. So you need to know what type of allergy. If she's simple, some abdominal pain, some diarrhea, or she develops severe anaphylaxis. So ask her what happened when you take penicillin, then I will document this in your notes. The other issue is foundation. When I asked you I don't have any financial support. I'd like it to be supported by the NHS. Don't tell her no, it will not be funded. Give her option. Tell her I will involve my consultant and you can talk with your GP because sometimes you need to do application form to the clinical commission group and they will decide whether it will be funded or not by the NHS. Because there is some certain criteria they need to consider foundation for the reversal. For example, if the person don't father any child before, or if there is accident to her, she has only one baby and unfortunately the baby died, for example. So there is certain situations you can consider foundation. So you are not the one to determine if it will fund it or not. Till here, I will involve my consultant and you need to apply form for the clinical commission group through your GP.
Yeah.
Because there is certain criteria for foundation of the reversal of sterilization. And when I told you that I don't think it's the right thing to be done for me during the cesarean to do the sterilization, and so till here, I can see that you are angry about the sterilization done for you. Let me see your notes, and still, if you are not happy with what happened, it's your right to do a formal complaint. If you find that she is angry about the sterilization, because she claims the doctor who did for her sterilization and conceived her that she needs to do the sterilization because of the risk of the future pregnancies. So if you feel that the doctor is angry, try to absorb her anger. Tell her that you understand her voice. I understand that you are angry about the procedure done for you. I need to go through your notes, and if you wish, you can do formal complaint for that.
Okay.
Okay, Dr. Nandita. Apart from that, you did it very well. Thank you for sharing.
Thank you so much. Actually, Dr. Asha, I was so sleepy and I was not expecting my.
Don't worry, in the exam you will not be sleepy.
Thank you so much. Thank you.
Thank you. So coming to the reversal of sterilization, what important point you'd like to ask in this task? So during the history, start as we said by an open question. Tell me more about your concern. Important point you'd like to ask is what method of sterilization? Because sometimes the type of sterilization may determine the success rate of the sterilization, of the reversal. Clinic sterilization carries a better success rate. So you need to ask about the method of sterilization. And you need also to ask about when was it done. Because also the time spent since the sterilization will determine the success rate of the reversal of sterilization. Because you know, the success rate vary between 30 to 90%. And this variation determined by those factors. Age at time of the operation done, type of sterilization, the length of the tube remaining, as Dr. Nandita said, we need to assess the length of the tube remaining by doing hysterosalpingogram or laparoscopy, whatever it's called, and also determined by the fertility of the male partner. So you need to ask detailed history about your male partner. She is now like a case of infertility. You know that she had tubal factor because of the sterilization. You need to rule out other causes of infertility. So go through the fertility to see if it's regular, so you can ask about PCO and premature ovarian insufficiency and so. You need to rule out tubal factor. Ask if she had any adhesion, if she had any surgery done before in her tummy, any history of sexual serve infection. You need to ask details of her male partner. If he ever fathered in a child before, what does he do for living? If he physically fit and well, did he do any semen analysis before? So details about the male partner, because this will affect the success rate of reversal of sterilization. Then don't forget to tell her about the risk of pregnancy at the age of 40. And she tell you that I already discussed this with my GP. So don't go through it. As long as she told you, I know, don't waste your time, and try to explain that you may carry a risk of hypertension, of Down syndrome, and so on. She said, I know, that's it. Go for the other. During counseling the patient, you need to explain what you will do during the reversal of sterilization. Simply draw for her. The procedure will take about 1 to 2 hours. It will be done under general anesthesia, and it will involve that because the fallopian tube, after drawing to here, till here, this is the fallopian tube, and it's a very delicate structure and need magnification to be seen. So we need to join the tube together accurately using very fine stitches to give the best possible results. And we will make short bikini line incision, approximately 10 to 12 centimeters in length across your lower tummy. And if you have been sterilizing using clip, These are then removed and the fallopian tube are joined together in 2 layers and draw that for him. The role player may ask you about the success rate, so you tell her this is determined by the age at which you did the operation, the type of method used, the length of the tube remaining, the fertility of the male partner. Before doing reversal of sterilization, you will need to do for the partner semen analysis. For the woman, you will do FSH level to determine her ovarian reserve, especially because this patient is 40-year-old. So you will need to do FSH level. And you need to assess the remaining length of the tube. And this can be done through hysterosalpingogram or at the site of the laparoscopy to see if you can rejoin the tube together again or no. Then you need to discuss about alternative. Alternative options could be either reversal of sterilization or IVF or adoption. And if you tell her about the IVF, she will ask you also, I need it to be funded. The same answer will be, you need to ask your GP to do application form for the clinical commission group to see if it can be funded or not. As you said, you tell her if you got pregnant following the reversal, you need to seek advice immediately in the early pregnancy unit to make sure that you have healthy intrauterine pregnancy, because there is risk of ectopic pregnancy following reversal of sterilization. Coming to the complication of the procedure, tell her that occasionally it's not possible to repair one tube. In 3% of cases, they can repair only one tube. And very rarely, it's not possible to repair either of the tubes. Sometimes you cannot repair any one of them. Besides that, risk of any surgery like infection, serious bleeding, especially here she had previous cesarean infection, risk of closing, shoulder pain, damage to the internal organ, history of clot. Don't forget to involve the consultant and to mention about the role of clinical commission group to decide if it's funded by the NHS or not. So we finish this task. Anyone have questions?
Yes, ma'am. Can I ask if the patient has a past? Is it important to ask the patient if she has a past history of sexually transmitted diseases or refer to a sexual clinic, because this may add to the pathology of the tube. Not only it is blocked, but there is an infection there, or if she received treatment before. Also, shall we ask about the update of a cervical smear or any abnormality about her cervical screening?
Yes, cervical smear is important. Yes, you need to ask. Regarding the first question, you need to ask about STI in any case of infertility, because this may add the risk of adhesion. If she has chronic infection in the past, this may increase the risk of adhesion and the risk of damage during the reversal of sterilization. You need to ask, yes.
Okay, ma'am. Thank you. Thank you.
Thank you, Dr. Sam. Any more questions?
Question, Dr. Akash. Do we
Yes,
have to
Dr.
explain the procedure to the patient?
Yeah, it's written in the task. You need to counsel her about your management options. So tell her what she will expect to have in the operation.
Okay. Like we will put the stent and we'll cut and join under, and this will be done by.
Simply draw and tell her what you are going to do. Draw for her the uterus and the tube, and that we are going to rejoin the tube together.
Okay.
It will help in your explanation better.
Okay, thank you.
Any more questions? Shall we move? Okay.
Dr. Asha, in this case, when she will go for this reversal, again we will say that we will check your status that hepatitis B, C, HIV, serology.
Sorry, Dr. Asha, your voice is not clear.
Same considered as in fertility.
Sorry?
My sound is clear or no?
Yeah, but repeat the question now.
No, I said because when she will go for this reversal, so again we will say we will check your serology, hepatitis B, C, HIV.
For reversal, no. But if she go for IVF, this needs to be done before IVF. But for reversal, no.
Okay. Okay. For IVF, it is the criteria.
Yes.
Okay. Okay.
Thank you. Any more questions?
Yes, ma'am. If the surgery tubal reversal of sterilization is it by certain doctors specialized in microsurgery? I mean, it is not the just a gynae doctor or consultant. There is some doctors which are more or centers more specialized in microsurgery. I will refer her to, or
Yes,
I mean, there is an MDT here. There is an MDT here in this station.
it's not like an MDT, just you will refer here for specialized fertility center if you wish, and at least involve your consultant to be on the safe side. Absolutely, you are not the one who will go for his reversal.
Yeah, because it is a highly sophisticated surgery. I mean,
yes,
whether
yes,
by
yes,
laparoscopy or laparotomy, so I have to refer her, I think.
Yes, but here because this is the first time she see a gynecologist, and she would like to know about her options. So mainly you are discussing with her the options, if reversal can be done for her, and what other investigation will be requested, and what is expected to be done during the procedure. This is the main task. She is the first time to come in consultation.
Yes, ma'am. And there will be time to explain to her the pros and cons of getting pregnant after 40. There will remaining time for that.
For what?
To explain her the difficulty of getting pregnant after 40 years.
If you have to, yes, but in the station, if she told you, as I said, I discussed already this risk with my GB, so that's it. Don't go through it. But if she don't know about the risk, you need, it's part of safety. You need to counsel her about the risk of pregnancy at the age of 40. But to save time, I think I already know about the risk, so don't go through it.
Okay, ma'am. Thank you.
Thank you, Dr. Scott. Shall we move? Okay. So, Dr. Nureen Khan? Dr. Fawziya, yes? Dr. Rashki? Dr. Salma Begum? Dr. Salma?
Yes, assalamu alaikum.
Walaikum salam. Okay, Dr. Salma. So this task assess the following clinical skills: patient safety, communication with patients, communication with colleagues, information gathering, and applied clinical knowledge. Mr. John Smith, who was following with your consultant together with his wife, as he had been trying to conceive for 3 years, has requested to see you. His investigation results showed azoospermia, high FSH and LH level, 46XY karyotyping, and hemoglobin A1C of 16. You have 10 minutes to counsel him, answer his concerns, and to suggest the management plan. You have now 2 minutes. Could you start, please, Dr. Salma?
Hello, I'm Dr. Salma, one of the doctors in the gynae clinic today. May I take your name in it, please?
I'm Mr. John Smith. I'm 35.
35.
Yeah.
What would you like me to call you?
Mr. John is fine.
Mr. John, how are you?
Yeah, I'm fine.
I understand that you came to know your report and you have time to conceive for 3 years. And you want to know the management plan. Do you have any other concern that you want to discuss today?
I know about the results that I don't have any sperm in the semen sample provided. I repeated it twice and the same result come back. But I don't know about the remaining test results, and I'd like to discuss this with the consultant.
All right. I'm sorry, you want to know, discuss with the consultant. I cannot hear you properly.
Yeah, because I know about that there is no sperm in the semen sample provided, but I don't know about my further tests, and I'd like to discuss that with the consultants.
Sorry, the consultant is not here today. He is busy with the other operation. Is it okay if I continue the conversation?
Okay, so you are not the consultant?
No. I'm a register.
Okay. Yes, okay.
Okay. So, do you have any other concern?
No.
So, so is it okay before explaining to your concern and management plan if I ask you some relevant questions, then in front of chaperone with your consent, the nurse will examine you and then will explain to you report and management plan, and at the end I'll give you the patient information leaflet. How does this sound?
Yeah, sound good.
Can you tell me more about your condition, Dr. John?
We are trying to conceive for about 3 years with my wife, but unfortunately the test results come back that I don't have any sperm.
And then? Hello?
Yes?
Yes. So, so how is your relationship with your partner?
Yeah. I know that there is no problem with my wife. All her investigations are normal. I know that the problem is from my side.
So, do you know your report already? You know already your report?
Yes, I told you that I know that there is no sperm appear in the semen sample, but I don't know about the remaining results. I did further tests after confirming that I don't have sperm in the semen, and I'd like to discuss about its results and my management options.
Okay. So, do you have any infection in your, when you are child at the time there is any viral infection or any trauma in your testes?
No.
Any radiation to your, testes for any reason?
No.
And sorry to ask you some personal questions. Do you have? Sorry, there is a background noise.
Okay.
I cannot hear you properly. I cannot hear you properly. Okay.
Yeah, I'm not speaking. Okay, can you hear me? Can you hear me now?
Background noise. Yeah. Yes. Thank you. So, sorry to ask you some personal questions. So, how many times do you do sex with your partner?
We are trying to conceive for about 3 years.
And any problem during sex?
No problem.
And do you, have you ever been treated with sexually transmitted infection?
No.
And do you have any other medical disease that you're following to GP, like diabetes?
No, I'm physically fit and well. Apart from the last few months, I started to suffer from fatigue and I gained some of weight. But I don't think that it could be the cause of disappearance of sperm in the semen.
Okay. So, do you have any surgery before?
Any surgery? Sorry, Dr. Salma, repeat this question.
Do you have any?
Hello?
Hello? Do you have surgery before?
No.
Hello? Dr. Rasha, I cannot hear you. I cannot hear you. It's totally stopped.
You can't hear me? Is my voice clear to everyone?
Dr. Rasha, sorry, I cannot hear you. No, it's totally stopped. Totally stopped. Okay. Hello?
Yes, I hear you, Dr. Salma. Complete.
Hello?
They can hear both
Yes,
of
now
us.
I can
Complete.
hear, but
I
before
hear
it
you.
is totally stopped. Sorry.
Okay, okay. So I will give you further 2 minutes for this. But just a minute, Dr. Salma, just a minute.
Yeah, there is a background knowledge. I don't know.
Is it more clear now?
Yeah, now it is okay.
Okay. So now you have 5 minutes complete.
I'll start?
Yes, yes, complete.
Yeah. So, do you have any surgery before?
No.
Any families? Do you have any medical disease that fall into GP? Sorry, any medical disease in your family?
Like what?
Hello? Like
Family history,
diabetes
like
or
what? Yes, I have a family history
any
of diabetes in both of my parents.
any genetic problem?
No.
This it is disturbing again, Dr. Rasha.
Dr. Salma, I think your voice is interrupted. I can't hear
Dr.
you
Rasha,
properly.
yes. No, yeah, it stopped totally. Your voice is stopped properly.
Okay, let's continue.
Your voice is stopped properly. Totally stop your voice.
My voice is stopped, really?
Now it is okay, but before it is stopped.
I stopped when you didn't ask me, and you will suspect this in the exam. If you don't communicate with the referee, he will not prompt you to ask you questions. I just answer your questions.
No, I cannot hear you because it is totally stopped. I'm asking you. I'm not getting any answer. I ask you.
Okay, so is it clear now?
Yeah, now it is clear.
Okay.
But before I didn't hear you. Okay.
Okay.
So, do any family history of any medical disease?
Yeah, we have family history of diabetes in both of my parents.
Yeah, all right. And anything that any genetic problem in your family?
No.
So, how is your parents now? They're okay?
Yes.
And last 4 weeks, do you have any low mood, depression, no interest to do anything?
No.
Do you smoke?
Yeah.
Hello? Do you drink
Yes,
alcohol?
I hear you. Sorry?
Do you smoke?
Yeah, no, I don't smoke.
Do you drink alcohol?
No, only socially.
Okay. Are you taking any steroid for your muscle cells?
No, doctor.
Are you taking any medication now?
No.
Do you have any allergy to any medication?
No.
To whom do you live?
With my wife?
There is enough support at home?
Yeah.
And do you need a height and weight issue?
I got some weight in last few months.
Sorry, do you need a height and weight issue? How much?
I gained some weight during the last few months, but I don't know about my weight and height ratio. But I gained some weight.
Okay, we'll check it. And so now, thank you for sharing all information. Do you want to add anything?
No.
So now, in front of chaperone, if you're concerned, the nurse will check your pulse, blood pressure, and temperature, and also she will check your urine deficit, that there is any infection or there is any sugar. Okay. And for examination, we'll refer to you for urenologist to see, to examine you if is there any abnormality or not. Okay. So now coming to your result. Hello. There is a background knowledge.
Yes. What about my result?
There is a background knowledge. Okay. So now coming to your report with your NSS number and your date of birth, your name, I can confirm that your. I'm sorry to say that your that two and hormone test, okay, which is follicle stimulating hormone and luteinizing hormone. These two hormone is high, okay, and also your this karyotype.
What does it mean? My hormones are at higher level. What does it mean?
Yeah, that means you know the testis, it is not working properly. Okay, there is a that's why from the brain there is a hormone. These two hormone is the brain is stimulated to your testis to secrete this hormone. But as your testis is not working, that means it is higher. That's why this hormone is high. Okay, and also your this karyotyping result. Okay, this is chromosome. It is 46XY, so it is normal. And your HbA1c, which is shows that you are diabetic or not, it is 13. That is, it is also normal. Okay. Clear? Okay. So, do you want me to continue? I cannot hear you. It is there is a background knowledge. Sorry, background knowledge.
Do I have diabetes?
There is a background noise. I cannot hear you. Yes, now it is okay. Can you tell me, please?
Do I have diabetes? Signs of Dr. Simon. I don't know where is the problem, but the other concern is that my voice is clear. I think this from your side. But please,
no.
Can you tell me?
Sometimes it is clear, sometimes it is totally, it is background knowledge. And I heard you before with other candidates. I hear you nicely.
No problem, Dr. Salma. Just tell me in points what you'd like to counsel him in Harry. I will give you only 2 minutes for counseling, okay? 2 minutes only for counseling. Even if my voice is not clear, I will not talk. Just tell me how are you going to counsel the role player about azoospermia. Okay?
Yes. So first of all, we have to, breaking the bad news. Okay. So that means I'll present as a role player, or I'll tell you, I'll explain you only.
Dr. Salma, the role player already knows that he has azoospermia. You don't need to break bad news. He would like to know the cause.
Yeah.
Why azoospermia. Okay?
Yeah. So. So it is high that so that means he is premature premature testicular failure. Okay, so FSH analysis is high. and the karyotype is also normal. Okay, and the hemoglobin A1C, that means he has no diabetes. He is not diabetic. Okay, so for the after breaking the news, then I can ask him that about the that I continue the conversation, or I'll give you another appointment because he needs any support. Okay, because he may upset about this result.
So can you give me any medication to help my sperm to appear in the semen analysis?
Semen analysis? No, actually, I would like to know about that your fertility want to get pregnant, isn't it? The option will be means will refer to you the fertility clinic. I inform my consultant also. So and you told already twice you checked your semen analysis. So this fertility clinic, they may offer you for the donor sperm, or they will do this the sperm aspirate from your testes, or the tube which is carrying the sperm. Okay, so they'll aspirate it, and then
be able to have any children in the future.
Sorry,
there's no hope. I will not be able to have any children in the future. There's no hope.
No. There is a chance that you can get pregnant. You can try for the for baby. You can try. That there is an option. One is that to aspirate as you they will see any sperm in your testes or epidermis. Okay, that means the tube which is carrying the sperm. So they'll take it from your testes, and they'll see how much sperm you have. So if it is very few, then they will do that one this procedure which is called XC. Okay, so and if they'll see the quality of the sperm also. Okay, so if it is not good quality, and there is a mobility, or the mobility and this structure is not normal, then they will do that cytoplasmic sperm the injection. That means to your partner the egg, they will introduce your partner egg, which is called D6. And another option is that if you have good quality sperm, that means they'll take your sperm from your testes, they'll aspirate it, and then with your partner egg, it will mix in the laboratory in a special media, and they to grow.
So the options you will discuss with the role player. You said you will discuss about XZ, if there is appropriate sperm in the sample taken from this secret biopsy, and the other option is donors insemination. Is that right? Would you like to add any other option?
No, if there is a no sperm at all, then you can choose the donor sperm, and and you can and another option is if there is a good quality but few sperm is there, then you can try for the IVF. Okay, IVF.
Okay. Any other option?
And also, even though you can try adoption also.
Adoption. Okay. And what about the diabetes?
Sorry, diabetes.
Yes.
This actually HbA1c, it is 13. 13 means it is normal, but we'll check your after 3 months again we'll check your HbA1c. That means it is calculate your blood sugar within 3 months, how your blood sugar is functioning in your body. Okay, so we'll repeat it after 3 months.
Does this patient have diabetes based on the hemoglobin A1C?
Sorry?
You confirm that he has diabetes or no? Does he have diabetes?
No, I ask you, here it is written that the HbA1c 13. Here it is written.
It's high, it's high. Okay, so what you will counsel here about whom you need to communicate with, because there is domain tested communications with colleague, whom you need to communicate with.
Yeah, this is endocrinologist. Will refer to her endocrinologist, diabetic doctor,
yes,
and to control her blood sugar.
Okay.
And
dietitian
also
as well.
we'll advise her to lose weight, to take the healthy food, and to cut down the sugar. And in this situation, some may difficult to cope up this situation, so we'll offer him for psychosocial counseling and also support group who is same his condition to share the condition.
Okay, thank you, Dr. Salma for sharing. So you did it well by setting from the start the aim of the consultation. But as I said before to Dr. Nandita, try to determine your role. Don't say I am one of the doctors in the clinic. Who you are? I am the registrar in the clinic. Please introduce yourself with the role. That's why I told you you are not the consultant, because I'd like you to don't forget to mention your role. You are one of the registrars.
Excuse me, Dr. Raka. Here, one of the consultants who is doing the tutorial. So he told that don't mention the register, because the patient doesn't know what is the register. So even though they told that don't tell about the senior doctor also, that tell one of the doctors. I'm one of the doctors. Here the British consultant, he advised us. Yeah.
Your level as an MRCOG, you are a registrar. So even if it is not written, introduce yourself as a registrar, because the patient is keen to know what about your level, who the doctor level he is talking with. Is he a junior doctor? Is he a registrar? Is he a consultant? So it's necessary to introduce yourself with role. And usually it will be written in the task that you are an ST5. Okay? And also you did it well by you did well also by putting your agenda, and you ask about some etiology, about trauma, you ask about radiation, about STI. But please, when you ask any role player about sexually transmitted infection, signposting that. Tell them, I know that talking about sex may be embarrassing, but I need to ask some questions, then ask your questions. Don't ask it without signposting. You ask about the family history, but try to be specific. As you see in the task, the patient has diabetes. So you need to ask if there is any family history of diabetes, any family history of similar condition to rule out genetic causes of azoospermia. And also, don't forget to ask about symptoms of diabetes. Ask if there is any change or in any frequency in urination, any fatigue, any gain of weight. So this can be clue for the symptoms of this newly discovered diabetes. And you did well by confirming the name and the NH's number on the results of the investigations. But you need also to check understanding. Don't forget to do this, Dr. Salma. Don't stop talking and imagine that the role player will tell you if he understands or not. You need to ask a question clearly about understanding. If you finish some part of information you'd like to say, ask him, am I clear so far? Does it make sense? So check understanding while you talk, okay? And as you said, the options will be determined after referral to the endocrinologist and to a fertility specialist, doctor of andrology. Her option depends on the testicular biopsy, whether it could be there will be sperm, so he will be a candidate for ICSI, or we can consider donor sperm, or adoption still could be an option. Thank you, Dr. Salma, for sharing. Let's talk about the task.
Yeah, thank you. Thank you, Dr. Asha. Here, HbA1c 13 is given, but here we are checking our that for the patient. Here they are, 38 and more than 38. Then it is abnormal, not 13. 13 is here. It is, but here unit not written. What is the unit? So that's why I was confused, because 13. What is the unit?
Yeah, in the
exam,
normal, the normal results. No,
yeah.
Listen to me, Dr. Salman. In the exam, whatever investigation is requested, you will find the normal result. The only thing that you cannot find the normal reference for that is the semen analysis, because you need to know the parameters of normal semen analysis. Apart from that, all investigation, you will be provided with the normal range. Is it
Yeah,
clear?
but 13 is normal here. I know here 13 is normal.
Yes. Okay, no problem.
I'm checking for myself also. It is 35, even though 42, they told me that not to, it is not diabetic. So
Yes.
they repeat it.
No problem.
42.
It's okay.
That's why I was confused.
No worry. In the exam, you will find the normal result, and you will not find this confusion at the exam. I'm sorry that I don't provide you with the normal results.
Yeah.
So let's talk about what important point we need to cover in this session. So it's a case of infertility. So go through the items of fertility history. Here is a main factor of infertility, and already it's confirmed that the patient has azoospermia. Although you need to confirm that it's the second semen analysis done for him, and he will confirm that, yeah, it's my second semen analysis, and still confirm that I have no sperm in the semen. That's why you order further test, and the patient here to discuss about the result of this test. So ask about all question related to the male factor of infertility. As you ask if there is any history of trauma, any family history of similar condition, is there any history of sexually shared infection before? Ask about if there is any problem while having sex. So go through all of this, and then ask, do you have any idea about your wife result? Did she do any investigation before? So he will tell you that my wife is normal, all investigations are normal. So go through the skeleton of the fertility history. Go all through the questions we discussed in the start of our session. Then, as you see in the investigation, there is hemoglobin A1C is very high, so the patient has diabetes. So in your focal history, you need to ask about symptoms of diabetes, polyuria, fatigue, weight gain, any positive family history. And also, coming to the domain of communication with colleague, you need to involve your colleague. You need to involve the consultant, the andrologist, the endocrinologist, the dietitian, and even you need to offer a meeting with a counselor. As I told you, if there is a hope, you can feel that I'm depressed because that the patient has azoospermia. So offer meeting with a counselor.
I
Coming to the applied.
I told about
okay, no problem. That's great. That's great. So coming to the applied clinical knowledge, as you did, you check the patient name and NHS number on the investigation. And remember that if the role player don't know about azoospermia, don't tell him, do you want someone to be with you because I'm going to give you a lot of information. Don't follow this protocol of breaking bad news, because azoospermia is something confidential, and don't over that for him. Don't over a meeting with his partner. Okay,
yeah,
but in this
I didn't.
I know, Dr. Salma. I
Sorry,
speak generally.
Yeah.
I know that you didn't do this, but sometimes because you know it's a breaking bad news, you may rush through offering someone to support him during your consultation. But don't do this if the patient don't be aware about the diagnosis of azoospermia. But here, the role player knows that he has azoospermia, so no need for that. Coming to how to interpret the
sorry, Dr. Asha, one question. If it is female, that if it is premature ovarian failure, so at the time, no problem. We can ask her, isn't it? That anybody with you.
Sorry, Dr. Salma, I can't hear you properly.
If it is female, then can we ask this if it is ovarian insufficiency? Then we can tell that do you have anybody with you?
If she is female and she is coming seeking the result of azoospermic semen analysis, you mean that?
No. If she is premature ovarian failure, so at the time we can ask the female patient that do you have anybody with you?
If you find that it is something sensitive, you can approach breaking bad news without talking that offer another one to accompany the consultation. Simply, you can say, do you have any idea about the results of the investigation? Because I don't have, unfortunately, I don't have good news for you. So you signpost the breaking bad news. You don't necessarily need to go through asking for someone to accompany while telling her about the results. If you feel that the result is something sensitive, like in patients with premature ovarian insufficiency or in case of azoospermia, you can just tell You have any idea about the results? Unfortunately, I don't have good news for you. Then go through the results. Okay?
Yeah. Yeah.
So coming to how to interpret the results. The role player already knows that there is no sperm in the semen, but how can I explain about the high level of hormone? So I will tell, as you know, Mr. John, there is absence of the sperm in your semen analysis. And in this condition, we name it azoospermia, and it could be due to either failure of the testes to produce them, or there may be blocked along the way they travel, or they may go through the wrong way and draw this from him. For your condition, you
Dr.
have
Asha,
high hormones.
your voice, sorry, your voice is breaking, please.
My voice.
Not clear.
Is my voice clear to everyone? Please confirm if my voice is interrupted. Is it clear or not?
Now
it is clear, ma'am.
Now it is clear.
It's clear, ma'am.
Now it is
clear.
Now clear. Before
I'm sorry, Dr. Salma, but I think there is net problem from your side because everyone confirms that it's clear.
No.
I'm sorry for.
No, I heard you before. I heard you before very clearly.
If you miss some of my talk, you can listen again to the recording. Okay? I'm sorry for that, Dr. Salma.
Okay.
So, how to interpret the results? As I said, you need to explain that. As you know, Mr. Jack or Mr. John, you have absent sperm, and we name this condition azoospermia. And it could be due to either failure of the testes to produce them, or due to block along the way they travel, or they can go through wrong way and draw that for the role player. In your condition, the investigation confirms that you have high hormones, and that means your tests are not working as they should. So a gland called pituitary is producing a higher amount of hormone trying to stimulate them to work. And in this condition, we order further investigation in the form of genetic makeup, because sometimes there may be problem with the genetic makeup, but it is not your case. Your genetic makeup is normal. Okay? So your picture is suggestive of a problem within your testes. That's how I can explain to him the high hormone level. Tell him that you know about the azoospermia, absence of sperm, and then explain the causes. And based on your result, because of the high hormone, it means that your testis is not working properly. Then you need to tell him about the plan of the new diagnosis of diabetes mellitus, and tell him that it can explain the symptom you suffered recently of the weight gain and the fatigue. This can be due to the diabetes. That's why we need to do a referral to an endocrinologist to put plan for this newly discovered diabetes. So what is the management plan for him? First, you need to do weight management. You need to, I will offer you a referral to a dietitian to discuss about that. We need to control the diabetes. And after doing a referral to an andrologist, he can advise you about taking sample from the test. And if they found a suitable amount of sperm, you will be a candidate for ICSI. And explain what is ICSI. It's test tube baby when we can inject your wild egg with your own sperm, then the embryo or the baby, the developing baby, will be transferred to your wild womb. And if it is not the case, and unfortunately we don't find any sperm in the sample taken from the test, so your option will be either donor semen or adoption. So remember that in patients with azoospermia, put in your mind the skeleton of the cause of azoospermia. Azoospermia could be either due to pre-testicular cause, there is secondary testicular failure, and this could be due to congenital problem like cystic fibrosis or congenital absence of the, in case of pre-testicular, it could be due to hypothalamic and pituitary causes like Kallman syndrome. You may ask the patient if he has problem with the smell. It will be specific question. You need to roll out Kallman. So do you have any problem with the smell? And also, the patient may have pre-testicular cause, like in case of hyperprolactinemia, any milk discharge from the breast, any headache, any visual disturbance. But in this case, because we find a high level of FSH and LH, we don't ask this question because we know it is not pre-testicular cause. because in pre-testicular causes, you will find low level of FSH and LH. The other cause of azoospermia, it could be testicular cause. The testicular cause, it could be either congenital or acquired. Congenital, like Klinefelter syndrome, but here the patient have normal karyotyping. It could be Y chromosome microdeletion. All of this can be determined from the karyotyping. Or it could be acquired due to previous injury, trauma, or torsion of the testis. So you ask about the trauma. It could be due to systemic disease like renal failure or liver failure. So you need to ask if he is physically fit and well. It could be due to chemotherapy and radiotherapy, and you did it well by asking about that. And it could be idiopathic, sometimes testicular failure without cause, idiopathic, and it is the most common cause. Or it could be post-testicular azoospermia due to obstruction. And in this condition, you will find the normal level of FSH and LH. The patient only have azoospermia, but all the hormones are normal. This is post-testicular cause. And it could be due to congenital condition like cystic fibrosis, or it could be acquired due to infection like chlamydia and gonorrhea sometimes can lead to obstructive azoospermia. That's why we need to ask about sexually shared infection. And it also sometimes could be a disorder of sperm function like motile celiac syndrome or immunological infertility sometimes may be the cause. Do not forget the normal level of semen analysis because it is the only test that can be provided in the area without giving you the normal results. You need to know that the normal semen volume is 1.5, the sperm concentration per milli is 15, the total ejaculation is 39, the motility, progressive forward motility is 32%, total motility is 40%, vitality is 58%. You need to find at least 4% of normal morphology, and the pH needs to be more than or equal 7.2. This is the normal semen analysis. Okay, hopefully this case is clear. If anyone have any question, please let me know.
Thank you, Dr. Asha. Dr. Asha, only one thing I would like to ask you, that Royal London, this course, they explained that IVF also, that how they mentioned that if there is a, that means abnormal this semen, like if there is a mortality problem or a structure problem, and it is not, quality is not good, then we can try ICSI by aspiration of the sperm retrieval. And they mentioned if there is a good quality, but few.
Yes, ICSI will be determined after doing the testicular biopsy. This will be determined after the testicular biopsy. If there is viable sperm,
yes. And they told that if there is a good quality sperm and few there is a few sperm if we find, then we can try for IVF.
Okay, all of this also will be determined following the testicular biopsy. Yeah, that's a clear point. Yes, Dr. Sam.
Yeah, so that's why I explained the Royal London. They explain like the Royal London course.
That's great. Any more questions?
No, thank you very much. Thank you for your effort.
Thank you, and thank you for your change of stance. Any more questions? Shall we move? Let's move, okay. So, Dr. Nurween, Dr. Nurween Khan, Dr. Fawzia Ayaz, Dr. Rajni Agrawal, Dr. Turabhi.
Hello, Dr. Asha. Good evening.
Yes. How are you?
Yeah, fine, Dr. Asha.
So, this is your talk. You are 95 and about to meet 46-year-old woman who has been in a same-sex relationship for the past 3 years. She has been referred by her GP to discuss conception. They intend to use one of their male friends' sperm to achieve pregnancy who works in a nightclub. Your supervisor discusses the case with you prior to you seeing the woman. You are expected to display the information required in counseling the woman and discuss the laws governing children born in this relationship. So this is a structured discussion task aimed to assess the following domains: information gathering, applied knowledge, communication with colleagues, and patient safety. Now you have 2 minutes. I will give you the question to think about it, but we will go through one by one. This is the question in this Bible. Try to think about its answer. You start, Dr. Strapke?
Yeah. Hello, I'm Dr. Surbhi, one of the exam candidate, and I'm ready for the discussion.
So what are the important and relevant features in history you will ask?
So as this is a patient with 36 years old, and they're the same sex couple, and they want the donor insemination. So I would like to ask in detail about the history regarding the age of both the partners and whether they are in the civil relationship or not. If yes, then for how long, as this will have a bearing on the parenthood of the children, legal parenthood of the child, and then I would like to know is there any previous history of any time they have become pregnant, any one of them, and have they decided who will be the birthing mother? And I would like to know about the medical condition of both the partners, whether they have any, to rule out any diabetes or any other autoimmune disease, because it will have implications on the treatment further. Then I would like to know whether they're allergic to anything, because if they might need any of the drugs, we will be careful. And I would like to know whether they have undergone surgery or not, and what is their occupation, and whether they have the full financial support for the upcoming child, and any kind of social support they want. And I would also like to know the body mass index of both the partners, as we will aim to have the birthing mother to be younger and healthy. And also, I would like to know whether any of the partners is smoking or taking any recreational drug or alcohol, so that we can optimize their condition before they try to go for the IUI. So after this history, I would like to examine the partner who is going to be the birthing mother
Information you give to the couple regarding the fertility treatments that may be used to achieve pregnancy.
Yeah. So I would like to tell the couple that first of all, they will need to decide who will be the birthing mother. Okay, and then we will rule out any other condition in them, and the body mass index, we will try to optimize that. And also we will, before going for the options, we will also need to check that the birthing mothers, the tube of the birthing mothers are patent, and also the birthing mother is ovulating. And then we have certain options like donor insemination, which in this donor can be the friend, as they have chosen already a friend. So I would like to
Would you
tell
like
them
to
that
ask any question related to the donor semen? They already have the donor. Would you like to ask any important history for the donor?
yeah, I would like to ask about whether the donor has fathered a child before, and whether the about also the medical condition of the donor, and also
Medical
whether
condition.
he is tested. What medical
Like
condition,
what? What
like
medical?
diabetes, to rule out diabetes, or any other condition, and also
Will it affect
HIV.
your, if diabetes will
Which
affect the donor semen? What specific medical condition you'd like to know about the donor semen?
the sperm count, the semen analysis of the donor they have chosen. We would like to know the semen analysis of the donor they have chosen. So we would like to check the tests to know
So
the
what
sperm
are the
counts.
fertility options?
And also the options are, they can have the arrangement privately at home for the donor insemination, but the risk will be that the such kind of donor insemination at home, the sperms are not, they don't undergo the checks, so there is risk of infections and also the genetic abnormalities. And if it is done at the licensed fertility clinic, the sperms, they undergo the check for HIV infections and other infections, other bloodborne infections like hepatitis also, and all the genetic conditions are also checked. And also the clinic has the full legal advisory, who will be the legal parent, and this donor will not be the legal father of the child if the couple undergoes this donor insemination in the licensed clinic. And the birthing mother will be the legal mother. The other option will be the IVF. If after the 6 cycles of IUI, the mother does not conceive, then they can go for the IVF, and we can write to the GP, and they will liaise with the clinical commissioning group for the NHS funding. And the third option is the adoption. They can adopt a child in spite of if IUI or IVF failure occurs, they can go for adoption as well. So it depends on their wish. And also, after telling about these, yeah.
For lesbian couples.
Pardon?
What are the roles on parenthood for lesbian couples? What are the roles of parenthood?
Yeah, if they are in the civil partnership, if the couple is in the civil partnership, they're automatically the legal parents of the child. Yeah. If they undergo the treatment in the licensed fertility clinic. But if they take this treatment at home and the private arrangement, then the legal father will be the person who is the donor, who is the donor, and the arrangement is done privately. And the legal mother will be the birthing mother, and the legal father will be the donor. And
what if they are not in civil partnership?
If they are not in the civil partnership, they will have, and they go to the licensed fertility clinic, they will have to fill the form at the time of, before the time of conception, they need to fill the form. And after that, they can be both of them are the legal parents of the child. And but if they do privately at home, then again the legal father will be the donor, not the other non-birthing partner.
And how they are recognized as joint parents? How can civil partner be recognized as joint parents?
Joint parents.
in order to recognize them as joint parents? What are the rules for that? What are the requests for that?
I think they should be in the civil partnership to be recognized as the
Yes.
joint parents, and the non-birthing partner can also should consent for this procedure, and they should not have any child before, I think, from some other partner.
What other information will you provide to the couple?
Yeah, I would like to tell them in this donor insemination, the donor is anonymous, but they can come to know about certain characteristics like ethnicity and the color of the donor, and otherwise the identity will be anonymous. But if the child is born at the age of 16, he can have the access to the access to the information of the father, and at the age of 18 he can get the address of the father also, and he can communicate with the sibling also if there is any sibling from that donor.
And what about the birth certificate?
What?
The birth certificate, what about it?
On the birth certificate, if it is done in the licensed fertility clinic, the father will be unknown. It will be written on the birth certificate as unknown. And if it is done privately at home, then nothing will be given on the birth certificate, but the donor will be the legal father.
Okay.
And
you'd like to actually say?
Yeah, in the licensed fertility clinic, the donor will not have any binding to bring up the child. He will not be held responsible for any financial help for the child as well. Whereas in the private arrangement, there will be legal binding with the father, because the legal father will be the donor one.
Yes, thank you, Dr. Sophie, for sharing. You did very excellent. You covered most of the point. I really don't have any comment on your performance. You did it very well. You have a good knowledge about this topic. But only just I'd like to add, be specific for the question. In the first question, I asked you what important relevant feature in history. So don't go through examination. No need for that. Be specific for the question. Another thing I'd like to tell you, if you don't understand the question in the Viva station, ask the examiner to rephrase the question. When I ask you about how can civil partners be recognized as joint parent, although you know the answer, you didn't give me the answer because I feel that you don't understand my question. So ask the examiner to rephrase the question. Tell you the question in another way. Okay?
Okay. Yes.
Apart from that, you tell everything in this station. You did it very well. Thank you.
Thank you so much, Dr. Asha.
So, about the first question, what are the important and relevant features in history that you will ask? You need to ask about the age of the partners. She and her partner, you need to know the age of both. You need to know the status of their relationship, if they are in a civil marriage or not. You need to know if they clarify who will be the birthing mother and who will be the non-birthing parents. And if they decided who will be the birthing mother, so you need to go through the fertility history for this mother. Ask if she has ask about her ovulation, ask about her period, ask about any history of sexual infection to assess the tube. Ask about if she's physically fit and well, if she has any genetic problem in her family. So ask about details of fertility history if they decided the birthing mother. But if the couple doesn't decide who will be the birthing mother, you can help them in deciding after taking a history of both of them, and you can counsel them that it will be better for the birthing mother to be the one who is medically free, who is younger in age, who don't have any problem with her fertility. But if they decide so, go through the fertility history for this birthing mother only. If the donor status is known, as in this task, they know the sperm donor will be one of their friends, So you need to know if this friend has any medical history, especially any genetic problem in his family or any history of HIV in his condition. This is the important information you'd like to know. Is my voice clear or no?
Yes,
Yes,
ma'am.
Dr. Asha.
Clear, okay. So this is the important information you'd like to know. The age of the partners, the status of the relationship, who will be the birthing and the non-birthing mother, the relevant history of the birthing mother, including her age and all the fertility history, as we said. In the donor, you need to know if he is screened for HIV or any genetic problem in his family. Coming to the next part, what information you will give to the couple regarding the fertility treatment that will be used from where to study this topic. Okay, all important points related to this topic from this slide. I summarize it in this task. You can take a screenshot and you will not need to read anything before, after that. So, what information you need to tell the couple about their fertility options? The fertility option will be either artificial insemination by private arrangement at home. They have already known donor semen, donor sperm, so they can proceed with artificial insemination at home. And remember that when couple using donor sperm and using intrauterine insemination, it will be intrauterine instead of intracervical because it improves the pregnancy rate. As you see in the lower picture on the left side, this is the intrauterine insemination. Small cannula introduced into the uterus and do the insemination intrauterine, not intracervical. The other option is to seek fertility treatment in a licensed fertility center, especially if one of them, the birthing mother, have problem with fertility. So they need to go for fertility center. The other option is adoption, and here in the adoption, some legal issues related to that. In order to recognize those couple as parent to the adopted child, one of this couple will be his mother. But for the other female in this relation to be a parent, she should spend at least 6 months with the adopted child before they apply for this court application to make sure that both of them will be the parent for this adopted child. So for adoption, court application cannot be made until the non-birth mother has lived with the child for at least 6 months, and the couple don't have to be civil partner to apply. Any couple, even if they are not in civil partnership, they can apply for adoption as long as they will spend 6 months with the adopted child, then they can apply for the court for the adoption. What is the role on parenthood for lesbian couples? So, lesbian couples who are civil partners at the time of conception will be automatically treated as legal parents. As long as they are civil partners, they are in civil marriage, and at the time they conceive, so both of them will be automatically treated as parents. But if they are not civil partners, what will be the condition? The non-birthing mother will be treated as child other parent, but this means that both parents sign consent form in a licensing center electing that the non-birth mother to be treated as parent before the date of conception. And this form needs to be fulfilled before conception. It will not be taken in consideration if it is signed after the conception. So, if they are in civil partnership, so both of them will be automatically be the legal parent for the child. But if they are not civil partner, the non-birthing mother to be elected and treated as a parent, both of them need to sign consent in a licensed fertility clinic, electing the non-birthing mother to be treated as a parent. And this form needs to be signed before the start of conception. And remember also, if the civil partner conceived by private arrangements at home using a sperm donor, the friend or the non-donor also have the right to be treated as a cousin. But if this insemination done in a licensed fertility clinic, he will not be treated as a cousin. How can civil partner be recognized as joint parent? Again, they must be stable partner at time of conception. So they will be automatically registered as legal parent to the child. The other issue is that the conception must be through donor insemination or fertility treatment rather than through sexual intercourse. If it is the child through sexual intercourse, this is not recognized as parents. Need to be through either donor insemination or fertility treatment in a licensed clinic. The other prerequisite is non-birth mother must consent for the conception. The birthing mother, it's okay for the birthing, but for the non-birthing, need to sign consent that she is agreeing for the conception. Non-stable partner who conceive outside the UK licensed clinic will not be qualified as parent. So this is the rule to be qualified as parent. They must be stable partner at time of conception. Conception must be through donor insemination. Non-birth mother must consent for conception, and non-stable partner need to conceive in a licensed UK clinic. What other information to provide to the couple? The birth certificate will record the birth mother as the mother and the non-birth mother as a parent. So in the birth certificate, this child will have mother, which is the birthing mother, and parent, which will be the non-birthing mother. And remember, donors who donate their sperm through a licensed clinic are not normally treated as being legal parents. But if donor semen with a private arrangement, so they can be legal parent for this child. They will not be protected, and they can be a legal father for the child. So remember, regarding the intrauterine insemination, if women conceive with intrauterine insemination, it's done without induction ovulation. But if more than 6 cycles over induction, so if it is a role player station and you now discuss with her the option of intrauterine insemination, you will tell her that we can do this procedure without giving the new medication to induce this ovary, as long as she is ovulating. But if more than 6 cycles without success, she cannot go pregnancy, so we can offer her as a time induction. The other issue is, before doing intrauterine insemination, you need to assess ovulation. But you don't need to assess the tubal factor. If there is no history indicated that there is tubal factor, the patient doesn't have history of adhesions, of surgeries, no history of STI, so don't assess the tube. When to assess the tube? If after 3 unsuccessful intrauterine insemination without success, so you need to assess the tube by doing a hysterosalpingography. Intrauterine is recommended than intracervical because it's associated with high pregnancy rates, and you can counsel the patient and tell her that 50% will succeed to have pregnancy after 6 cycles, and further 25 after the other 6 cycles. So the success rate will be 75%, 3 and 4 after 1 year. Remember that if couple in the same relationship, so their options will be intrauterine insemination. Sometimes the patient may see that both couples need to be linked to the child, and if it is the case, they will be counseled about IVF using egg donation from one of those couples, while the other couple will be the birthing mother. So both of them will have link to that child, and if it is the case, this needs to be in a licensed fertility clinic. XZ is not an option. Intracytoplasmic sperm injection is not an option because they will conceive using donor semen, and the donor semen usually need to have a normal semen analysis. So there is no indication for XZ. It will be simply through test tube baby IVF. I finished. If anyone has any question, let me know.
Dr. Rasha, could you please explain this adoption thing again? That I didn't understand. Like 6 months they have to live together.
Yes.
What was that?
Okay, in order to adopt a baby and to be recognized as parent for that baby, they need to spend with the child at least 6 months before application for this court application. They will sign court application, but to sign this and apply for adoption, because in adoption, both will be parents. They will be legal parents for that child. So in order to for this application to be successful, they need to spend at least 6 months with that child before applying for court application for adoption to be recognized as a legal parent. Is it clear now?
Dr. Asha, I could not understand about the this ISHKI part. What was it?
Sorry, about what?
About intracytoplasmic sperm injection part.
Yeah, intracytoplasmic is not an option because they conceive through intrauterine insemination, so they will have donor semen, and no, in donor semen they will have a good quality of sperm. It will not be a case of oligospermia or azoospermia, so we can proceed with ICSI. ICSI is offered only if there is no sperm count, and it will not be the case in case of donor semen. Is it clear?
Okay, thank you.
Welcome.
So, Dr.
Any more
Rasha,
questions?
so
Yes.
how many total IUI cycles these couple can have? IUI cycles?
How many? Okay, for
Total
insemination, total
yeah.
12 cycles. After that, they can seek for IVF. Intrauterine insemination, the success rate after 1 year is 75%. First, you will make sure that the birthing mother is ovulating and she don't have any suspected risk factor for tubal factor of infertility. So proceed with intrauterine insemination. After 3 cycles, if no pregnancy occur, you can assess the tube patency by hysterosalpingogram. After 6 months of unsuccessful intrauterine insemination, you can use induction. After 1 year, they can proceed for IVF. Is it clear now?
Yes, thank you.
Any more questions? Okay, thank you all for attending our session today and see you next time. Thank you all.
Thank you, Dr.
Thank you,
Rasha.
Dr. Rasha.
Thank you, Dr. Rasha. Thank you.
Thank you. Are welcome.
Thank you, Dr. Rasha.